is going to be boring. Some of it's going to be redundant, but please, stop me for questions. You don't have to wait until the end. There's, it's not like we have 50 people in here. So I'll go ahead and get started. So my name is Bianca. I am the Director of Education and Strategy here. Everyone here is really tries to be helpful. So whenever you're in doubt, you can always message me or Dr. Rosing, especially about clinical things or really even sales. I've been a nurse for, I don't want to age myself, but for about 25 years. And I've been in post-acute sales, specifically wound care, for about 15, and in a lot of leadership roles within that. So I'm very familiar with the market spaces, and I'm very familiar with clinical needs and stuff. So any questions about those things, you can always reach out to me, and I'm happy to help. And I'll let Dr. Rosing introduce himself before we dive into everything too.
Yeah, so I'm Dave Rosing. I'm one of the providers here. Recently the chief medical officer. So yeah, I'd like to help out as much as possible. We're trying to get the orientation thing as smooth as possible. There's like a lot of moving parts in terms of getting the Slack going and email going and just kind of getting used to how the flow goes. So Bianca and I really want to make that as easy as we can for you guys. So it does not bother us to reach out at night, doesn't matter. Please feel free. Any kind of questions are welcome. Welcome, Morgan. Tariq, good morning, sir. But yeah, it's not a bother. So if there's anything that's not working, or you're having frustrations, reach out to just both of us, and we'll try to take care of it as well as we can for you.
Yeah, we're pretty available. I try to update my Slack if I'm, say, driving or something, so then you'll know, like, oh, Bianca's not getting back to me because she's busy. I really try to not ignore everybody. I try to get back to this. I get anxiety if I'm not responding. So you'll probably get a response fairly quickly from me if I'm not getting a response. Either the message got lost or I'm super busy. But I do try to communicate pretty quickly. So
same. Yeah, if you don't hear back from us in like a day, then
there's something wrong.
We're probably missing.
Yeah, send out, call 911. We're definitely put out a missing persons report. All right, so I'm going to go ahead and start. So first off, welcome to Omni. We are a leading provider of mobile wound care, and we have a high focus on patient outcomes and collaborative care. Me and Dr. Rosing and a lot of other members of the team are constantly finding new cutting edge technologies or finding ways to actually heal wounds. Not saying that every competitor in the business isn't about healing wounds, but there are some out there. We don't want to extend the period of care just to keep our numbers high. We want to make sure that we're healing wounds, and we really do provide patient-centered care here. So what to expect during orientation with us. So you're going to get education from me and Dr. Rosing. You're going to have some communication with the orientation team throughout the process. For the providers, you should have already received your shadowing schedule. If you have not, please let us know before the end of the day so we can coordinate that. At the end of your shadowing, me and Dr. Rosing will have a brief meeting with you to discuss your comfort level. Did you, get everything that you needed during the orientation? Is there any questions, clarifications? If there's any additional trainings that you may need. Before your first day of rounding solo, where the orientation team will reach out to you to ensure you have all your relevant information, that you're able to get into your Wound Ally, your tablets working properly, that you got your supplies, or if any, you have any last minute questions on where to get your patient list or about consents or anything like that. Additionally, after your first day of rounds, typically that first day, I'll send out a message with me, Dr. Rosing, and sometimes depending on your position, somebody else might add that chat. We might add to that chat, and just to discuss how your day went. That first day in the field, you're going to be like, okay, now some of the stuff that they went over into orientation that I didn't fully absorb, now I know. I'm kind of putting two and two together. Maybe I need some clarification on that. So that's another reason we do that, and then to help give you tips on how to make things smoother or any hiccups that you experience, just tips and tricks that we have. As far as provider shadowing, so that all depends on your level of experience. So as Dr. Rosing was telling Diana there, she'll be placed with a couple providers to do in-person hands-on training. So, and that training will be at skilled nursing facilities and patient homes or wherever they reside. They can reside in a boarding care, an assisted living, group homes, private residence, or a skilled nursing facility. When you go out and you're doing the training, you're going to have like different procedures that you're going to do. You're going to do debridement, potentially negative pressure application, definitely G tubes. You want to make sure that you're at least doing 3 G tubes out in the field before you're, tasked to do those alone. Order writing, how to do documentation, real-time wound ally use, real-world assessment, and collaboration with the wound care teams. At the end of everything, you will have a recap with Jamila. Jamila is one of our clinical educators. She'll go over some comprehensive wound assessment. She'll retouch on pressure injuries, go over lower extremity ulcers, treatment modalities, and then EMR training. So you'll kind of get a sandwich approach to the EMR training. They will actually be reaching out to you this week to schedule some pre-training, and then they'll be doing some post-training too. Obviously, we know that doing a lot of stuff front-loading you, it's not necessarily all going to make sense, so you're not going to absorb it as much until you're actually using it. Additionally, anytime that you have any questions about anything, like we said, we know that there's going to be so much information that's going to be thrown at you today. We don't expect for you to absorb it all. Just reach out to, us, and we will navigate you to the correct person. So, if you get stuck on something on the EMR, we'll connect you with the CED team to assist you with that. I'm going to start with rounding days. This is what a typical day looks like. So you can have a combination of home health, hospice, and facilities in one day. And there are some key differences between those types of locations. So a facility, typically you'll see these, type acronyms. So skilled nursing facility, nursing home, long-term care, congregate living health facilities, subacute rehab, or convalescent home. A lot of them, they're very similar. Actually, they're all considered post-acute, so their billing is all the same. But for us, what's really going to be different, so a SNF, nursing home, long-term care facility, or long-term care and convalescent home, those are really the same. A lot of custodial care, or maybe some skilled nursing, rehab that maybe somebody had a stroke or a surgery and now they need some post-acute care to get them back up to their normal strength level before they can go home safely. A congregate living health facility is the same concept as those, but those are typically large homes that were converted into a smaller style nursing center. Subacute rehabs are typically attached to a skilled nursing facility, and those are going to have your higher acuity patients, typically vents and trachs. Any questions on those? So home visits. So locations for home visits, those can be boarding cares, assisted living, senior apartments, private residence. And just because somebody is in an assisted living doesn't necessarily mean that they are in a nursing home. So it is a different point of service because assisted living don't provide necessarily nursing services. So just something important. You'll probably, if you get an address at an assisted living home, you could see 2 patients there, or it could just be 1. Hospice. So hospice visits can be in the home visit category or facilities. It's really the hospice referring out to us. Sometimes they'll be in a nursing home because they're there because they need a lot of care, or they'll be at home on hospice. So what to expect at facility rounds. So upon arrival to the facility, the first thing you typically do is check in with the treatment nurse or the assigned station nurse. Most facilities will have a treatment nurse. Some don't if they're smaller or they just have a different structure. I know there's been a lot of structural changes with the pandemic because of nursing shortages. And sometimes the actual nurse that is doing their meds will also do their treatments, but it's not as common. But whoever that person is that you're assigned to meet, that's who you meet with. We will let you know who that person is in advance. You want to obtain a patient list from the nurse and review any new patient charts, and we'll go over what you look for in that later. This is very important, is that you want to ensure all consents are completed prior to seeing the patients. We're ultimately responsible as providers for the consent being in place before any treatment's provided, and we cannot see them by any means if there's not a consent, whether it's verbal or in-person signatures. The office staff does support you, and field assistants do support you as well in getting those signed, but ultimately as a provider, it is your responsibility to ensure that it's completed before seeing the patient. Additionally, in nursing homes, typically there is no rounds during mealtime. That is a regulatory issue. If you are doing rounds and the meal trays are out, they can actually get a citation. So please keep that in mind. Some facilities don't care. Most of them do though. So be aware when you're giving your ETAs or you're trying to make your schedule. Typically trays are out between 11 and 1. Sometimes 11 and 12, depending on the facility, but make sure you're communicating that so you're not, disrupting anything or putting them at risk for a citation. So you want to collaborate with the wound team. So, treatment nurses, of course, because you're going to be rounding with them, primary care physicians, DON, the podiatrist, vascular doctors, the dietitian, your Part B dressing company representative, and I'll get into all of these a little bit later, and other vendor representatives. And what items to bring during your visit. Now, please keep in mind, we will give you these supplies. Most of them, if you haven't already received your supply package, it should be coming soon. But things to bring in, of course, your curettes, lidocaine, any silver nitrate, rulers, your tablet that will be issued to you, a clipboard for your shorthand notes and consent forms. We do a lot of things electronically here, but in nursing homes, a lot of times we're able to get the consents there. And we also do shorthand notes there because we want to make sure we're leaving a note behind for them. Because if Department of Health comes in and we didn't leave any notes, it could be a problem. So our typewritten notes that come from your shorthand notes do take about 24 hours. So we want to make sure that we're leaving them with something. So we do leave our shorthand notes there. A light to visualize the wound. G-tubes if you're doing a G-tube change, gastrographin for the G-tube, and grafts if applicable. And that's pretty much the same on home visits as well, with the exception of shorthand notes. You're not going to be leaving those behind in the home environment mostly. And what to expect during facility rounds continued. So use all interactions with the team as a learning and teaching experience. So remember, we can learn from everyone, regardless of the letters after their name. It's very important that we provide good customer service and that we're listening. Just because, you may have 18 letters after your name and that person maybe just has LVN, it doesn't mean that you necessarily know everything that they don't know. These nurses know their patients intimately. They see them every day, day in and day out. They've been doing treatments on them before you came into the picture. So what they have to offer us is invaluable, and we really want to promote a collaborative environment. Additionally, we do have some nurses, and Dr. Rosing, I'm sure, can chime in on this, that can be difficult, and maybe they think they know more than you, and they just have an abrasive personality. We just have to navigate that a little bit. Like, we have to tell them that they're wrong while we're telling them that they're right, and just be delicate. But it's really important that we don't come in egotistical. There is a lot of competition in this industry, and they're waiting for us to slip up for anything, whether it be a late note, you rolled your eyes, whatever. So I want to make sure that we're being collaborative, we're being respectful, and we're really listening, because I can tell you that having been a nurse and I have other degrees, I learn from people that don't have degrees or that have only been a nurse for a week because they saw something I didn't. So it's really important. And I don't know, Dr. Rosing, if you want to chime in on that at all.
Yeah, it's just the whole wound care experience really is a big collaborative team, and we're all parts of that team. Each part is equally important, and like Bianca said, the treatment nurses, these are their patients that they're with every day, so really their insight is invaluable. And coming from a surgical background where I came from, I learned most of my wound care experience through the field assistant that had already been rounding for several years in the field, and from treatment nurses. And then I did my own study on the side. So humility really goes a long way. Please respect all those team members and everything will go well. But yeah, in the end, the The patients, the facilities are our clients. We need to treat them as such. I'm not saying that, the customer is always right type of situation. You need to know when to apply your education and knowledge. But all of this, even for them and for all of us during this whole time, is a learning experience. So the more collaboratively you work, the happier everybody is, and the less issues all of us will have. And at the end, the happier the patient will be, and the better the wounds will heal. So that's it.
Additionally, so when you're dealing with challenging situations, we want to make sure that you consult your supervising MD. As far as the supervising MD channel, you actually will have a channel with direct communication on Slack with that supervising MD. Myself and Dr. Rosing are in those channels as well. We don't chime in too much unless we notice that the supervising provider maybe hasn't got back to you in a timely manner. Sometimes they're rounding too, so they haven't been able to get back to you, but we try to chime in when those are when there's any delays. But those are a great way to ask any questions, whether it be how do I write this order, or how I have a problem. Also, you can consult with Dr. Rosing if your supervising MD is not available or is something they can't answer. Some challenges that we do see in facilities is request to change documentation. They do get in trouble for facility-acquired wounds, and sometimes they want us to change that. Obviously, we don't want to break any laws, and we don't want to do anything that's going to risk our licenses. So those are some challenging situations because we don't want to make them unhappy, but we also don't want to lie. So, come to us when those situations occur, and we'll review the chart with you, and we'll discuss what's the best option, and if there's a happy medium. Nurses not changing dressings, you will see that from, sometimes, unfortunately. So come to us, or come and we'll navigate you through those challenging times to try to keep the referring agency happy while advocating for the patients. Patients can be non-compliant, and there's challenges within that, so we can help guide you with those things, or orders not carried out. We also want to make sure that you leave your shorthand note with the nurse at facilities before you leave. It's very, very important. So I'll stress that again, because they will ask us and they will call the office. I didn't get my note, and they kind of freak out a little bit. So please make sure you're leaving that with them. Of course, make a copy for yourself for your own reference. Always double check with the treatment nurse that your documentation matches exactly. It's really challenging when our notes maybe say it's a stage 4 and theirs says it's a stage 3. So I want to make sure that we're on the same page. We should typically always be, because we're collaborating when we're doing these documentations. But that's just something to double check, making sure that you're on the same page. On completion of rounds, check out with the DON or representative to communicate any necessary items and build rapport. So it's really important that before you leave, you go to the DON and say, hey, we went and, we're seeing 15 patients. If there's any outliers, right? So maybe this is where you're going to address the nurse didn't change the dressing, or maybe they have a new nurse and you think they would need some education from our team. So you want to communicate that. Maybe there's a challenging patient that's non-compliant and you want to discuss some additional plans of care. So that's where you'll do that. And just kind of give them a summary. If there's nothing wrong with perfect rounds, just still go in, check out, and say, hey, I just finished, I saw 15 patients, everything went well. There's no, nothing that's really standing out. I'll see you next week. But it's really important that we build this rapport with them, and we have an open line of communication with them at all times. So hospice patients versus home health. So hospice patients, Omni does order the supplies for the patients through our Part B dressing providers. Supplies are sent monthly, so please keep that in mind. And also when you're doing family education or caregiver education on the dressings, make sure you're being clear with, hey, this dressing is changed once a week or 3 times a week, because they're only going to get supplies that match your order. So that's always important. And hospice patients, just to note, and I'll go over this a little bit more later, they're not always conservatively treated. So make sure you discuss the wound care goals with the family and IDT team before just assuming that, oh, they're hospice, I'm just doing, keeping them clean, odor-free, and free of infection. Sometimes the hospice patients do want aggressive treatment. So like I said, I'll get into that a little bit more later. For home health patients, one of the bigger differences is the home health agencies are responsible for sending the supplies to the patients. Typically, those are also sent out once a month. If you come into issues where the home health agency is not fulfilling the orders, communicate with our team. We do have some trunk stock that you can leave behind. We try not to make a habit of it or leave more than 7 days at a time. But that is something we don't want our patients to do without. Technically, we're not supposed to leave it, but we don't, want to neglect our patients. But in the event that the home health agency is not sending supplies, that's something that you would want to communicate to your business development manager. If you don't know who that business development manager is, you can send myself or Tariq a message, and we'll coordinate that and get you in touch with that person so they can go out and talk to the home health agency on what we expect as far as supplies, or what's, maybe what's going on with the supplies not being ordered or whatnot. So with home health visits, what to expect is your schedule will be available on Wound Ally for the respective day, and you'll get your Wound Ally training, so you'll see what I'm talking about shortly. Confirmation calls are made the night before. Typically, your field assistant will do that. In the event you don't have a field assistant, you can ask the office for support to make those confirmation calls. Then you will also receive a confirmed and unconfirmed patient list. It will be posted in your Slack channel. Like I mentioned, this is typically done by your field assistant. And if you haven't, I think you guys all got signed on to Slack yesterday. Am I right? Yes? You guys can just give a thumbs up. If you haven't, give me a thumbs down and we'll re-coordinate that.
I did.
Did somebody say they didn't?
I did.
Okay, perfect. So all providers should have their own channel, and that's where all of this stuff will be communicated. And it is very important to monitor your Slack. I know you guys are going to be in the field. I typically, whenever I'm out in the field, I stop. And I don't want to say stop after every patient because you don't want to mess up your flow when you're in a facility. But if you're in a home care environment, I would, check after and before you go to your next patient, because there could be some relevant information. Once again, ensure your consent is obtained before performing any treatment on the patient. Like I said, we communicate consents that are completed or not completed. So if consent is not done before you get there, when you get there, if the patient can't sign for themselves and there's no power of attorney or responsible party available to sign it or to give verbal consent, we cannot treat the patient. So I'm going to stress that probably throughout this a lot. It's very important that we obtain consent. Also, please utilize your supplies, not the patient. So the patients will have their supplies at home. And like I mentioned earlier, they do get a finite amount based on your order. So we want to make sure that when we're there, we're using our supplies, not theirs, as we don't want to deplete what they have. So home visit etiquette, we want to introduce yourself to the patient, caregiver, and family members. We want to make sure you're explaining all procedures and the plan of care to the patient, caregiver, and family before beginning care. So, when you're rotating the patient, or, hey, I'm going to change your foot dressing, so I'm going to take it off. I'm going to pour saline. It might be a little cold. We want to make sure we're explaining those things. I know we mostly know this, but just a reminder, I think sometimes when we're not in a hospital or nursing home environment, sometimes we forget those things. So just a friendly reminder. We also want to make sure you're explaining the treatments to the patient and the care team, and ensure that they understand what you're doing and why. Communicate any plan of care changes to the team and the family. And of course, answer all questions regarding the plan of care and treatment. Because they're at home, and a lot of times maybe they only have a home health nurse coming out, a couple times a week or maybe once a week, the family or the patient will be taking care of that dressing. So you want to make sure that they understand what their role is and what the plan of care is, so that they're able to perform it while you're gone, so we get good healing outcomes. We want to also ensure that you're cleaning up after treatments are completed. Dispose of sharps in the appropriate container. I'm sure you got a little bit of information on the sharps containers that you are issued. So making sure you kind of bring that in and put those sharps containers there for home care. Most home visits aren't going to have a sharps container. So you want to make sure you bring your own. Make sure that you're not leaving a mess. Sometimes dressing changes and treatments get a little messy. So clean up after ourselves. Make sure we're leaving the location the way we came into it. Additionally, you want to make sure the patient is left in a comfortable and appropriate position. We don't want to leave them on their side with, the diaper half exposed. We want to make sure that they're comfortable, they're in a position appropriate for them, based on, if they have a G-tube or whatnot. So I want to make sure we're doing that. And that is it for that. Does anybody have any questions before I move on? Okay, so now we're going to go into a multidisciplinary approach. I have touched on this already, but this is something that, again, like I mentioned earlier, there's some things that I'm going to go over repetitively because they're very important. So strategic partnerships, we want to ensure that we have healthy relationships with partners at facilities and agencies. Partnering with other vendors and facilities is necessary for growth and continuity of care. They can build your territory. Now, we have Part B partners, and I'll go into Part B a little bit later, but they are at pretty much every facility that we go to, and they bring in, they supply dressings for patients that have Part B Medicare. And having a good relationship with them will, one, get you really great continuity of care. But in the event that a patient runs out of supplies, sometimes you can kind of ask them like, hey, can you help me get some supplies over here? I really need some help. And it also, if you have a good relationship with them, they have a lot of facilities, and a lot of times they'll push you in and be like, oh, I really love working with Dr. Rosing. So anytime I see that my facility with another doctor in here is having problems, I'm going to push for Dr. Rosing. So that's definitely a help for us as well. So nurse collaboration, like we mentioned earlier. So there's a lot of things that nurse collaboration does. So it does improve patient care. It provides comprehensive and safe care. Like we mentioned earlier, nurses provide hands-on insights, and they complement doctors' medical knowledge, and it helps reduce errors and improve outcomes. These nurses know these patients intimately. They're going to know if you put a dressing that needs to be changed every day, that patient may be non-compliant, right? Or they may know that if you have a dressing that's only being changed 3 times a week, that this patient, maybe wants to shower every day. So it might not work, right? So, listening to them, collaborating will help make those outcomes and decisions better. It also helps efficiency. So it helps streamline processes. Effective teamwork reduces duplication and ensures timely care and optimizes resources. Enhanced communication helps clear and coordinated care. Better communication ensures that all team members are informed, reducing misunderstandings and improved coordination, such as maybe you go and you do your rounds and you order a low air loss and you put it on the note, but you don't necessarily tell them. Sometimes they miss things on notes. They're not reading the whole thing. So, just communicating that like, hey, I think this patient needs a low air loss mattress. It helps ensure that there's no gaps or anything missed. So strategic partnership, again, ensuring healthy relationships with partners and facilities. So I don't know why, is that twice? I might have put that twice. My apologies. So nurse collaboration continued. So holistic approach, we do want whole person care. When we talk about whole person care or patient-centered care, we're not saying it because it's a cute buzzword that's trending in healthcare. We really mean it. So we want, we want to combine the medical treatments with emotional and social support to make it comprehensive. We have to understand what's going on with the patient to provide the best orders and plan of care for compliance reasons. Money situations can inhibit certain things. So we want to make sure that we are talking to everybody and ensuring that is appropriate for that patient's level of everything. Professional development, we mentioned this earlier, mutual learning. Collaboration enhances skills and knowledge for both doctors and nurses. Dr. Rosing is a great example that he is a surgeon, been in OR for many, many years, and he comes to wound care, and a nurse took him around and helped his skills, elevate in the wound care industry because it is very niche. So it's very important that we look at it that way. Additionally, collaboration makes everyone happy. It provides a supportive environment. I know for me, when I have a really strong team around me and it's not, it just makes my day go by faster. Everybody's happier. I feel like that makes the patient happier. So it's definitely helpful. And that kind of goes into patient satisfaction. I think patients, I know for me, if I go to the provider and I see everybody kind of miserable, I'm like, ooh, I don't really feel great about this. But if I go in there and there's a warm environment and you see the nurses and the doctors talking, I feel more confidence within that care that they're going to give me. So ancillary partners can be your push partners. They do they do help with better outcomes. They build an outcome approach patient patient care, or outcome approach to patient care, and it fosters growth. Like I mentioned, they're going to push you into other buildings. If you have some, you make a relationship with a Santal rep, maybe a certain patient can't afford Santal. It's just outside of their budget, and you're like, hey, I think this patient would really benefit from it. And sometimes they can give you some samples to help facilitate that patient need. And they can also bring you leads into other buildings or other referral sources. So it's always good to have ancillary partners. I'm a big proponent for that. You can really build your book of business without having to do much, just by having trusting relationships. So once again, team approach. So building a team to provide better healthcare for your patients. You want to have reliable partners. It does help with effective services. It does help with better patient outcomes. The comprehensive assessment collaboration does help provide a better plan of care for your patient. And then this also helps with field assistants. And I don't know if any of the field assistants joined in, but when you're a provider, you will have a field assistant most of the time. We'll go into how many patients you need per day to get one of the a field assistant. But a field assistant is really going to be your right hand. They're there to make your day go smoother. You can see more patients, you get more done just with their support. And typically, they will anticipate your needs. They're going to, as you get to know each other, they're going to know, okay, Dr. Rosing uses this type of dressing on this wound. They like to do this on this wound. You'll have a flow. So maybe they'll take off the dressing while you measure, or vice versa. While you're, finishing documenting, they'll put a new dressing on. So it's a really great collaborative approach. It helps your days become more efficient. And it's just a benefit for you. I don't know if Dr. Rosing wants to chime in on how a field assistant helps your day. If not.
Yeah, I mean, the field assistant is critical for any provider. They're so helpful. It gives you that extra set of hands, also gets you an extra set of eyes. And as they get going, I mean, for the most part, I had never thought about putting skin grafts on patients. And the field assistants are always like, hey, what do you think? I'm like, that's a damn good idea. So really a good collaborative team approach. And you guys are really end up being partners for the most part. And my first field assistant was John Mazet, who's now field operations director. And so that relationship is key. And I really hope you guys both, like, from the field assistants, you can learn a lot from the providers and vice versa. So that relationship is great. And you guys can really both help each other out, make each other's days a lot better.
So here we kind of go into how we assign field assistants. So field assistants are assigned to providers that have at least 10 home care visits in a day and 15 SNF patients in a day. They will be your right hand in ensuring you provide excellent patient care. They maximize round efficiency. They also assist in building relationships with facility staff and patients, family members. And collaboration with your field partners is imperative in ensuring smooth and efficient days. They will be doing your routing. So if you have, 15 home care patients, they're going to do your route, and having that trusting relationship, that, okay, they're not going to have me going from one side of Burbank to the other. They're going to do it in a systematic manner. And that's just one less thing for you to have to do. They're going to do your confirmation calls. They'll help you with getting your consent. So it's really a great partnership, and it's a great asset to have. I think that's one thing that's really unique to Omni, is that we really try to support the provider in every way, whether it's an extra cost for us or not, just to make your day smoother and to really allow the providers to focus on wound care and healing the patient rather than the other, I don't want to say monotonous, but the other kind of nuances of the day. So it's definitely helpful. Field assistants and provider roles and responsibilities. I will email you the larger version of this, but essentially it kind of breaks down the responsibilities. And you can see the field assistants have a lot of responsibilities. So they're definitely a big help for you guys. But, what we want the provider to do is really do the chart review, accurate documentation, a thorough HPI, timely notes. So we want the notes same day submitted, so there's no delays in getting them to the referring agency. Of course, you're going to be responsible for all the wound care treatments, verify prior completion of consent and or obtain, Like I said, I'm going to mention again, consent is ultimately your responsibility in ensuring that it's completed before providing care. Your field assistant does support that process and try to help you obtain it, and so does the office, but ultimately it is your responsibility. We want to make sure that the providers they know they're responsible for the effective communication with primary care physicians, nurses, field assistants, and other ancillary staff. Communication with the family of the patient being served. Care management and treatment plan, and treatment procedures and education. So you are going to be responsible also for educating that family on how to do the dressing. Field assistants can support you in that if they have, a thorough knowledge on that, but ultimately that is your responsibility as well. The field assistants will, assist you in uploading the consent to the patient profile and Wound Ally, ensure that you have adequate supplies in order when you're running low, assist you with, instrumentation, setting up, I don't want to say a sterile field, but a clean field within, when you're, especially in home care environments, wiping things down, assist you with taking photographs and measurements. They can help you with documenting on the handwritten note or the shorthand note, or it really is going to be your whatever flow works for you guys. But they'll also help turn and reposition your patients. They'll place requests for labs, antibiotics, and things like that on Wound Ally or in your Slack channel. They'll help complete lab requisitions and label swabs while you're out, and assist with ensuring that the low air loss that you ordered last week is there, and reminding the nurses like, hey, last week we ordered a low air loss, we don't see it here, things like that, just to kind of be that second set of eyes. Sometimes we get kind of blinded. We're just kind of like, here, I'm here to do the wound, and you completely forget that, wait, my patient's not on a low air loss that I ordered last week, and they can kind of catch those things, and vice versa. So it's just, like I said, it's an extension of yourself. It's just a added benefit. Etiquette. So I know we mentioned this earlier. Oops, let me go back. Etiquette is very important, and I'm going to share this. So you will receive a copy of this, but Omni Physicians does have rounding etiquette. So we do place a strong emphasis on maintaining a high standard of professionalism among all its medical practitioners, doctors, nurses, NPs, field assistants, everybody. This is a non-negotiable expectation, and it applies uniformly across all settings and all times. So, when you go to rounding, it's very important that you arrive with your necessary equipment. You want to arrive on time. We know that things happen. Maybe you gave them an estimated arrival time of 10:30 to 11, and the facility before took a little bit longer. Making sure you're communicating that with them so they're not sitting there waiting, right? Because they are waiting for you. They're expecting you. Obtaining and reviewing the patient list and checking for new admissions. Review new patient H&P and other pertinent medical documentation, such as meds and whatever comorbidities they're having. Review any previously ordered studies, consult notes, and other pertinent medical documentation. That's going to be important for your lower extremity wounds. Ensure completion of consents and leave documentation appropriately. Submit needed documents to medical records or upload directly to the patient profile, and that's mainly going to be your consent forms. Communication. So communication with the director of nursing and treatment nurse. After rounds, I already kind of went over this. Check out with the director of nursing. If the director of nursing isn't there, see who is that person in place, and it could be the administrator if they have an ADON, but we definitely want to make sure that you're checking out with somebody. In the event that nobody is available, I would leave a little handwritten note, hey, I came, this is a little bit of a summary, and put it under their door. That way you've done your part. You always want to use professional language and maintain a respectful tone, address colleagues by their appropriate titles and names, and establish efficient communication channels. Collaboration. We kind of went over this, another horse that we're going to beat. A collaborative environment, we want to foster that, team-oriented, encouraging open communication among healthcare providers. Gone are the days where nurses should feel scared about asking a doctor for something, or voicing their opinion. So we want to provide a safe environment. We want them to feel heard, and then we want them to feel safe in saying, hey, doctor, I don't think you should order this because XYZ. So we definitely want to provide a collaborative and safe environment. We also want to provide collaboration with ancillary and complementary organizations, making sure we're on the same page with them. And I'll go into, you're going to hear about Part B a lot. We do a lot with our Part B providers, and there's certain documentation that they require in order to get our patients certain dressings. So that's where we kind of go about maintaining a collaborative environment with them. We go over patient-centered care again. We want to prioritize patient well-being and provide patient-centered care. We want to be mindful of their unique needs. They all have wounds, but all have different backgrounds and different understandings too. So we want to make sure that we understand if they have any gaps in knowledge or where maybe there are some shortcomings, whether it's a language barrier or maybe they have some cognitive impairment or whatnot. So we want to make sure that we're addressing those things. As far as roles and responsibilities, we want to clearly define roles and responsibilities to minimize confusion. And we want to understand the scope of practice for every licensure. It's important to know that your LVN treatment nurse can't do debridement, right? So we want to make sure that you're not trying to have anybody do things that are outside of their scope of practice. Your field assistants can't do debridement. That is definitely a provider-centric task. So we also want to consult the appropriate specialty when in doubt or have specific questions about a case. And I'll go into that a little bit more when we're getting into complications. Continuing education. So we want to make sure that you're maintaining ongoing education and professional development. We will share updates on advancements in wound care. We hope that if you find something that you share with the team, we do have a provider channel that we ask you to share. And if it's something that everybody can benefit from, we also have an all staff channel. Share. We all love to learn. We also want you to coordinate with the education team for external education. If you have a facility that maybe they have a new treatment nurse and she's absolutely clueless, that's going to affect our outcomes, right? So we want to make sure that they're trained and our patients are getting good care. So getting them connected with Jamila and team. Patient handoffs. So conduct effective and thorough patient handoffs. So maybe you're going on vacation and Dr. Rosing is now covering for you. Of course, your routine patients that don't have a lot of complications, you probably don't need to necessarily do a big thorough handoff. It's pretty straightforward. But if you have a patient that's very complicated, you want to make sure that you're communicating that with the oncoming provider so there's not any gaps missed or they don't go in and change your treatment orders thinking that they're inappropriate, but they're actually appropriate because, you've done XYZ. So communicating those things is always important. Of course, confidentiality, this kind of goes into HIPAA. We want to adhere to patient confidentiality and privacy regulations. We want to make sure that we're not discussing patient information in areas where other people can hear. No, I think Armando went over all that HIPAA stuff with you, but just a reminder. Also, cultural sensitivity. We want to be culturally sensitive and respectful of diversity, recognize and address cultural or language barriers impacting patient care. There are different things that we need to be aware of. Certain religions we know they don't allow you to have blood-borne or blood-derived type products. Some cultures do not allow the women to speak for themselves. So we want to just be aware of those things when we're providing care. End of day reporting. So this is something, so at the end of your day, you want to send a list. And if you have a field assistant, they will be doing this. But if you don't, you want to send a list outlining if you've seen the patient and listing the patients that weren't seen. This is very important because if a patient wasn't seen, we want to make sure that we reschedule them to be seen later, or they're removed from your schedule. Say you didn't see a patient because they passed away. We want to remove them from your schedule for the next week for efficiency reasons. Or like I said, if they're missed, we can reschedule them for a later day. So that's all very important. As far as, so I'm going to share this document. So end of day, I'm not going to go too in depth of this. This is something that it's pretty straightforward. So the end of day summary must be sent to the scheduling team, and that's going to be within your channel, your Slack channel. So missed patients with reasons, documentation to support reaching out to the referring agency. And I'll go into that a little bit later. If you didn't see the patient because they didn't answer the door, things like that. There's a whole policy on that. So I'll go into that a little bit later. Field manager will have all the field assistants. They are trained to send a message in the designated Slack channel confirming that they sent the end of day summary. In the event that you don't send your end of day summary, the office does have a policy, and this kind of goes into that. This is why I'm not going to go too in depth on this policy, because it kind of goes from everybody involved, not just the providers and field assistants. But in the event that you don't send your end of day summary, the office will be reaching out to you and saying, hey, I need this end of day. So make sure you're keeping track as you're going, so it's accurate. Any questions on any of this so far? Okay, so visit management. This goes into when these are more for home visits. Actually, these are specific to home visits, right? So we have a whole procedure on this because home visits are a little bit more involved than a nursing home visit. So the evening prior to visit, mind you, scheduling will go when we get the referral. They get that referral, they assign it, and they put it on your calendar after they've already spoken to the patient. So they do schedule it with the patient for that initial visit. But the evening prior, because they could have scheduled that on Monday, it's now Friday or whatnot, we do have confirmation calls, and that's typically done by your field assistant. If you don't have one, it is your responsibility. If you do need help because it's just you've had a busy day, you can send a message in your Slack channel and say, hey, I need some help making confirmation calls, and they'll go ahead and help you do that. Also, so your field assistant will make a list. They will put confirmed or unconfirmed on that list, and they'll put that in the Slack channel. If unconfirmed, further attempts are made in the morning by the office to go ahead and call and confirm it. And the agency, the referring agency, is contacted for assistance if necessary, if we just absolutely can't get through. So prior to departing to the patient home, the field assistant calls the patient and provides an ETA. So typically when you get to patient A's house, the field assistant should call patient B at that point and say, hey, we're about 30 minutes out, 45 minutes out, or whatnot. If there is no answer at that point, and this is specific to unconfirmed, call the referring agency and ask them to assist in reaching out. Sometimes people don't answer their calls if they don't know the number. So maybe they'll answer that agency's number. So we want to make sure that, we're communicating with the agency for any assistance that is needed to ensure that the patient is being seen. Now, here's something to note. If it's unconfirmed and you've also called and you can't get through, that doesn't mean that we don't want you to go because it was scheduled. However, as long as it's on the route, if it's something that's way out of your way and it's going to take you a 45 to an hour outlier and back to a different area, those are situations that we kind of look at a little bit more comprehensively. And we may call the office and say, hey, I can't get a hold of them. The agency, and talk to the agency, I can't get a hold of them. Nobody's able to get a hold of them. That may be a reason where you don't necessarily drive an hour out of your way. But other than that, if it's on your route, we typically go whether they're unconfirmed or not. And then if you get there and there's no answer at the door, whether they're confirmed or not, we want to go ahead and call the patient when we're there. We also want to call the agency again and say, hey, I'm here. No one's answering the door. We've had situations for numerous reasons where maybe the patient is, slow to get up and we're knocking and we're like, oh, it's been 2 minutes, I'm out, right? And maybe they're in the restroom or something. So we want to be cognizant of that. They are older and they have a little bit of mobility challenges, some of them. So be aware of that. We want to make sure we're doing everything while we're there to make sure that we're attempting to get through to them, calling the agency, calling the office. In the event that we cannot get through, we've knocked on the door, we've let the agency know, we want to go ahead and leave a note on the door. We do have a little sticky that says, sorry, we missed you. We take a picture of that. We send that in the Slack channel and send a little summary. Went to John Doe's house, spoke to Maria at agency ABC. Nobody answered. Here's our picture. This is for a couple reasons. One, we want to engage the agency to help us. They want their patient seen. We want to see the patient. Two, a lot of times the agencies will get pretty upset if they're finding out the next day or maybe by the patient, like, hey, I wasn't seen. And they don't understand why. So we want to make sure that we're constantly communicating with them because they could have helped us potentially, right? Not have a gap in that patient's care. So that's one reason that we definitely want it. And I don't know if Tariq is still on here, but I'm sure he can attest to getting a call from an angry referral source, even when it's not our fault, is just not pleasant. So everything that we can do to be in constant communication with them and being collaborative and asking for their support and being communicative about the patient not answering is very important. So this kind of goes into the office procedure. I'm not going to bore you with the whole process, but essentially, if you've gone, we've done all these steps, you weren't able to see the patient, you left the note, then the office will go ahead and start trying the rescheduling process with them. And then they'll put them back on your schedule when that's determined on why they weren't there or what happened. So any questions? Are you guys still good to go? Does anybody want a break? I'm going to power through. So this is Part B dressings. I'm going to not go, there's a lot of content in here. You will receive a copy of all of this data. And additionally, after you're out in the field, providers, we will set up a meeting with you to go meet with a Part B specialist so you better understand the required documentation that they need to get these dressings. This is just going to be a kind of quick macro overview. I'm not going to go into everything here. There's a lot of data here. So like I said, you will receive a copy of this in your package with all your supplies. So what is Part B dressing coverage and how do I know who qualifies? So Medicare Part B dressing coverage covers medically necessary wound dressings for patients with surgically created or chronic wounds. They have primary dressings applied directly to the wound, such as alginates, foams, and hydrocolloids. They have secondary dressings that they cover used to secure the primary dressings or enhance the wound environment. What dressings are covered by Part B? Like I said, this is a lot of information. I'm going over it for the sake of introducing it to you. But we'll go and have a meeting after. So once you're kind of in the field and you're understanding a little bit more about wound care. So full thickness, dry, no exudate has a whole different type of wound dressings and what they are able to provide than say a full thickness light to minimal exudate. Like I said, I'm not going to go through all these. You will actually receive all of this right here, these charts. You'll have a whole packet with all of these charts on each page and you can read through them. Like I said, we'll have a meeting. I'm not going to go through all of them, but there's different dressings for full thickness, moderate exudate, full thickness, heavy exudate, partial thickness, dry to no exudate. It's going to have a different dressing, partial thickness, light to minimal, partial thickness, moderate, partial thickness, heavy. So each of these, when we talk about partial, full thickness, and the exudate, if you have a full thickness wound and you write moderate exudate, but you're ordering a heavy exudate dressing, it will not be covered. And that's why it's really important to understand it. Documentation is key. So like for an alginate or other fibrogelling dressings covers and are covered for moderate to highly exudative full thickness wounds, so like 3 or 4 ulcers. And alginate or other fibrogel dressings, fillers for moderate to highly exudate full thickness. So like I said, this is a lot of information. I am not going to bore you with all of this now. This is here for you guys to reference later. We will have a meeting. I go into this pretty in depth on alginate, collagen dressings, or wound fillers that you're going to use. What they're used for, contact layers, foam dressings, and wound fillers, gauze non-impregnated. These are just some of the things that you're going to see out there. Gauze impregnated water, normal saline, hydrocolloid dressings, hydrogel dressings, specialty absorbative dressing, transparent film, wound filler that's not classified in any of the ones I mentioned previously, wound pouches, a zinc paste impregnated bandages, different type of tapes that are covered. And there's like non-covered items. And then, so like I said, I kind of blew through that because it's just a lot of information that I don't necessarily want to bore you with right now until you're in the field. And then we have a specialist come and sit down with you, me, Dr. Rosing, and the specialist, depending on the area that you're in, will meet with you and we'll go in depth on those. You'll have a greater understanding once you're out in the field and you're seeing this in real life to really gauge what I'm talking about on that. Anybody need a break? We're good? Thumbs up? Okay.
I'm good. I'm good.
Okay, perfect. So advanced services is something that we utilize a lot of here. And what's considered an advanced service or an advanced treatment in wound care is we're going to have ultramist, we're going to have grafts, there's negative pressure, HBO, things like that that are a little bit more expensive, but they provide really great outcomes. And typically we use them after a conservative treatment has been done for a few weeks. Ultramist treatment or ultramist therapy, also known as low frequency ultrasound therapy, is a non-invasive treatment primarily used in wound healing. It uses a low frequency ultrasound sonic waves with a saline mist to promote wound healing, and it reduces pain. It's actually a painless way to debride wounds. It has been clinically proven to promote the healing process against a wide variety of chronic and acute wounds. So we're using them on venous leg ulcers, diabetic foot ulcers, deep tissue pressure injuries, surgical wounds, and many other wound types. One thing that's important to note when you're using ultramist, it is a machine, and you do have to be issued it. We do have a few here. We're in the process of buying more. But before you can use ultramist, you do have to have 4 weeks of conservative care documented prior to initiating ultramist treatments. Or the only exception to that 4-week rule is if that patient has a lot of pain when you're doing debridement and they definitely need a debridement type therapy, then you can go ahead and initiate ultramist before that 4 weeks of conservative care, but it does have to be documented that there was pain. So some contraindications, and you're going to notice a trend that most of these advanced treatments are all contraindicated for malignancy. So ultramist is no exception to that. You don't want to use it on a malignant wound. You don't want to use near electronic implants or a prosthesis on gangrenous or stable dry eschar, or on the lower back during pregnancy over a pregnant uterus. That's coming from their website. I don't think I've ever seen a wound care over a pregnant uterus. Dr. Rosing, have you?
I haven't, but the one thing is that if somebody does have, say, like a cardiac stimulator in the wounds on the leg, you're safe to use it. You just don't want to use it if the wound was over the chest.
So typical ultramist treatment schedule, this is another thing to keep in mind when looking at adding this. It does require 3 visits per week. So when you're looking at, is this patient appropriate for this? Do they have the ability to be seen 3 times a week? Do you have the ability to go to that certain location 3 times a week? Or is there another provider that can work with you in tandem? Maybe they do the debridement, you do the ultramist, things like that. But the office will help support you with that. But it's just really important, first and foremost, does the patient have the ability to be seen 3 times a week? Typically, it's 2 ultramist treatments and 1 debridement visit. And just to note, ultramist can be used in conjunction with a graft. But if you're using a graft and ultramist, the ultramist treatment must be 48 hours after the initial graft application to allow the graft to kind of settle within the wound. Amniotic membrane grafts, also known as amniotic tissue grafts or skin substitute, skin grafts, there's numerous names that people call them. It is a product used to treat chronic wounds, and they're derived from an amniotic membrane of a donated placenta. It's a very, very popular treatment that a lot of people are using. It's been around since the earliest 20th century. It's really probably exploded within the last probably 5 years. It's been very commonplace to use them. They provide an extracellular membrane scaffold that helps the wound heal optimally. They are a very expensive treatment, so not everybody qualifies. It's something that we do run insurance on prior to placing. Indication for usage on the grafts. They are also one that needs 4 weeks or greater of documented conservative treatment. That there is no exception to that rule here. In actuality, there has been some changes that are going to take effect in February, requiring some additional documentation for VLUs and DFUs. We will share that information with you more as we get closer to that date, because there is some rumors that those that it may not be enforced. So we don't want to confuse you guys until that is 100% for sure. The wound does need to be a chronic full thickness wound, or actually just a full thickness wound. Doesn't necessarily need to be chronic in nature. Well, I guess after 4 weeks, it could be considered chronic. No infection. There can be no insurance restrictions. Like I said, it's a very expensive treatment. So there is a lot of inhibition of ordering it because of their insurance. The wound should have 80% of granulation tissue. If they are on anticoagulants, they do require additional documentation. And if they are in a skilled nursing facility or a post-acute care facility, they must be custodial, not skilled. And the difference between custodial and skilled, custodial is they're there as a long-term care patient. They're not there under their insurance for skilled needs, such as a post-acute admission where they had a stroke or maybe they had a hip fracture and they're there for rehab. When they're no longer on that skilled level of care and they're on custodial, then you can look at adding it if needed. You guys don't necessarily have to worry about that. We'll worry about that on the back end, but just something to be aware of when people are talking that language in the nursing homes. Contraindications of usage is going to be the use of corticosteroids, smoking, malignancy, and any presence of wound infection. Standard application and orders. I'm not going to go too in depth on this. We actually do have some videos that we will share with you before you do your first graft application. I'm going to probably just skip through this right now, just because it's just more information for you to absorb. That I'd rather have your attention on some other stuff. Before you do your first graft, the graft team will reach out to you. They will provide you with a video. They will provide you with all of the ordering and documentation. One thing that I do want to stress is that grafts are only applied once a week. The graft is considered the primary dressing. The secondary dressings are going to be what covers it. So you'll put whatever that may be. That can be changed more than once a week. We try to encourage them not to unless it's soiled. And we do actually have a sticker that says, if changing this dressing, please don't remove the graft from the wound. If the graft is not in that wound for the full week, it's not as effective. We don't have any science yet. Dr. Rosing has been asking on how many days it needs to be in place to be determined as effective. But it definitely should be there for the full week if we can keep it there. So negative pressure wound therapy. It used to be really, really common to see these in nursing homes. I mean, we still see them, so it's really important to know. But negative pressure wound therapy, it's been around for a long time. Common name that you're going to hear is wound vac. And so it's also known as vacuum assisted closure. It's a therapeutic technique using a suction pump, tubing, and a dressing to remove excess exudate and promote healing in acute and chronic wounds, or second and third degree burns. I've seen negative pressure on a variety of things. It works great. It's just really expensive. And so a lot of times you're not going to see it in nursing homes. You may see it in home health a little bit more. But it's definitely something that is out there. Indications for usage. I mean, you can see there's a long list: acute wounds, traumatic wounds, dehisced wounds, pressure ulcers, chronic and open wounds. I mean, really, almost any wound qualifies for a negative pressure at this point. The only contraindications you're going to see is fistulas to organs and body cavities, or maybe a fistula that's not explored. I have put on a wound vac on a patient that had an unexplored fistula that we were not aware of, and bowels started coming through. So that's one of the reasons that we want to make sure they were explored. You don't want to use negative pressure over necrotic or dead tissue or eschar that has not been debrided. It's not going to regrow dead tissue. Osteomyelitis. If they have osteomyelitis, you want to treat that first, because it's just going to reopen wounds due to skin cancer or cancer in wound margins or contraindications. Negative pressure, there's typically two types of foams. There's actually more, but the ones you're mainly going to see are black foam, which is used in most wounds. That foam is hydrophobic, meaning it does not absorb the water. White foam is typically used in tunneling. It's a little bit denser, firmer, so you can stick it down into those tunnels a little bit easier, and that is hydrophilic. It does absorb the water. Standard settings for negative pressure, typically 125 millimeters of mercury of pressure. That's for black foam. It does typically increase when they're using white foam because it's denser and it's a little bit harder to pull the fluid through. Usually increase it to about 150 millimeters of mercury of pressure. These are just recommendations. That's not set in stone. I've seen all different settings depending on if the patient has a lot of exudate and a lot of foam. They'll sometimes make it a little bit higher, or if they have a lot of pain, sometimes they'll put it a little bit lower so they're not having constant pain in that wound. Typically, they are changed 3 times a week, Monday, Wednesday, Friday, Tuesday, Thursday, Saturday. I have seen them less because post-op, I've seen times where a surgeon will actually staple the foam into the wound and they only want it changed once a week or maybe even less, depending on where they usually do the first dressing change. Of course, we all know that, but sometimes they'll want it changed a little bit less based on the type of wound. So,
yeah, especially if it's a skin graft. One thing about wound vacs is that you want to make sure if you're going to use them in the home setting that the family is familiar with it. A lot of the times they usually are, or they just need some teaching. But same actually goes for the facility. Sometimes the facility is only one treatment nurse is familiar with it, and then if there is, say, a problem and that treatment nurse is off for 3 or 4 days, a lot of the times they'll just leave that wound vac on, not functioning for 3 or 4 days, which definitely worsens the wound. So we always put in our orders, if there's any malfunction, remove the vac and just do a moist to dry or wet to dry, but that doesn't always happen. So always going to make sure if you're going to use it that the facility or the people taking care of the patient in the home are at least familiar with it. They work great and they're awesome for deep wounds that need to get granulating, but if everybody doesn't know how to use it, they can actually become a problem and make the wound worse.
Yeah. Whenever there's not suction for greater than 2 hours, they need to remove the whole dressing. That's important to note. It will cause like bioburdens to build up and all this. It's really like this, you're putting really like a plastic tarp over this wound. So if the suction's not on, it's just like sitting there in a little pool of just exudate. So it's really bad and can cause maceration. So if there is a time where you do have a patient that maybe the family seems to not understand, or if you're in a nursing home and you come back after the weekend and it's completely macerated and it looks like it was turned off, it's probably better to either do some education with them or change to a different treatment if they seem to not understand. Hyperbaric oxygen therapy is a medical treatment that involves breathing oxygen in a pressurized chamber. The air pressure in the chamber is 1.5 to 3 times higher than normal air pressure, which helps the lungs absorb more oxygen. And the goal is to increase the amount of oxygen in the blood to help the body heal and fight infections. We currently don't have any HBO in our practice. We're not using any mobile units. It does require clinic visits. It's pretty costly, and it does require the patient to be in a chamber for extended periods of time. It is a great treatment for an appropriate patient, but it's not something that we're practicing right now. Eventually, we're going to open some clinics, and maybe we'll have HBO therapy then, but as of right now, it's just not something that we're really using in our practice. All right, so we're going to get into documentation. This will have some redundancies on the next few videos. Please note that the redundancies are things that are very important. I said before, we don't expect you to gather every bit of information from this. You're getting a lot of information handed to you. Please reach out for any questions, clarifications, or anything as you're progressing with us. So I think we all know the old adage, if it isn't documented, it didn't happen. Documentation really is our first line of defense. In 2 years, you're not going to remember your plan of care for that plan of care, let alone that patient if questioned. So make sure you're documenting everything. You also want to make sure that you're documenting in a clear manner. Sometimes we think we're documenting clearly, but we're not, right? So it can be, we don't want to leave anything for interpretation. So everything that we do, we want to document. We want to make sure that everything's thorough. Our HPIs are very thorough. It is our best way to ensure collaboration and consistent care. And the documentation also needs to be consistent and accurate. We don't want to go fall into that copy and paste type mindset where I'm just pulling forward what I did last week. We want to make sure that they're all unique. Lawyers do look for that. Also, is it really accurate if you're just copy and pasting? So just keep that in mind. The documentation areas that we're going to cover right now is going to be HPI, defensive documentation, what is an unavoidable wound causes, some noncompliance, what are some examples of noncompliance, reasons for noncompliance. We'll go into all of those things. What we do when there's noncompliance, so any referrals out that may be needed. We're going to go into malnutrition, documentation, end of life, medications that slow or inhibit wound healing, infections, smoking, illicit drug use, socioeconomic considerations, vascular interventions, and family and caregiver education provided. So the HPI, and Dr. Rosing, please feel free to chime in whenever you want here. This is very, very important. So documenting the history of present illness is a critical component of the patient's medical record. It provides a detailed narrative of the patient's current health issue and is essential for diagnostic and treatment purposes. So the HPI it's important to know that not just your initial HPI needs to be thorough. Every HPI should be thorough and reflective of what that care was provided that day. So of course, we want to provide a brief statement of the reason the patient is seeking medical care. For example, heel wound. We want to address the chronology. So when did it start? How long has it been there? Are there additional wounds present? Is there any, what is the peri wound? Things like that. Want to document the location. Is there any radiation? So that's like I mentioned before, peri wound, things like that. The quality. So how does the patient describe like the wound pain? Is there pain? Sometimes, in a stage 4 on the coccyx, there may not be any pain. However, a skin tear on the forearm may have pain. So we want to document what that pain is, how it's described, if it is described, and we also want to do the intensity. Are there any modifying factors? So what makes the wound worse? Is the patient immobile? Are they incontinent? Did they have some medical emergency recently where they were in a motor vehicle accident, or they had a stroke and were in ICU on a vent for an extended period of time? So what kind of aggravated that situation? Are there any things that can help make the symptoms better? So frequent position changes, low air loss, mattress application, different things like that we want to add into our note. Associated symptoms. So is there any pain? Is there any infection? Do they have any, are they diabetic? Do they have any vascular insufficiencies? Those things are very important to document. And context. So what was the patient during when the wound began? Like I mentioned earlier, did they have a stroke and they were in ICU for an extended period of time on a vent? I hate to say it out loud, but the reality is that a lot of our wounds are going to be specifically our pressure injuries will be obtained either in the patient's home or in a acute care hospital. Not talking bad about acute care hospitals. They're there to address a medical emergency, and that's keeping the patient alive. So a lot of times when the patient's in ICU, they're more worried about stabilizing them and getting them to a point where they can go to a step-down unit versus turning and repositioning frequently. So we want to make sure that we're aware of that. Do they have any paralysis? Things like that are going on that are contributing. We also,
real quick, Bianca, I was going to say the HPI really should be a story of everything that's kind of going on when you see that patient. So you have to explain if this is a diabetic wound or an arterial wound or a venous wound. You want to kind of give the context why you think that, and that's where you can also add in. There's no palpable pulses, and there is a place for examination. But in the HPI, especially in that first one, you do want to kind of explain what you're thinking, so that if a lawyer, or let's say it's me, I'm gonna read your HPI. I want to be able to understand your thought process, why you think it's this kind of wound, and what are the factors that are going to inhibit this wound from healing, and kind of your plan. So if there aren't palpable pulses, are you going to get a Doppler? Are you going to get an ABI? If the patient's got venous stasis, what has been done for it? Are they wrapping it? Is there compression? If it's pressure, what led to that pressure? And what are they doing now? Or what is your plan to alleviate that pressure? If it's on the heel, like float the heels, lower LS mattress, heel protectors, waffle boots, etc. So the HPI really has to be a narrative so that if anyone picks it up, they can read it and understand exactly what's going on with the patient. That's for your initial HPI. Each week thereafter, then the HPI is not as detailed, and it's more like what has happened in that week. The wound has gotten worse. Looks like there's possible infection now due to some odor and some redness around the wound. I'm going to take a wound culture and start prophylactic antibiotics, and then tailor those antibiotics based on what the wound culture shows, something like that. So that there's sort of a narrative that goes with each note, because that's usually the first place anyone who's going to audit a note is going to look. And you really just wanted to imagine that your boss is going to be looking at that note. So document it well in that area, so that anybody who picks it up can understand what's going on. And then one last note is for that initial HPI that you get, and the first time you see a patient, these are debridement, et cetera, are surgical procedures. So we do have an informed consent form that the patient or caregiver or power of attorney is going to sign, but I also document it in that note. So I'll do my whole HPI narrative, and at the end, I'll write in capitals, informed consent. And then I'll write the risk benefits of alternatives to wound care, including debridement, were discussed with the patient and or power of attorney, risks including but not limited to bleeding, infection, worsening of the wound, possible need for surgery in the future, and the patient and or power of attorney agree to proceed. So that will help protect you. And it's basically a ways of having two forms of consent. So usually in my first initial visit, even if it's a patient that's been seen by another provider in a facility, I always put that, because that means that I myself discussed this with the patient or the family, not somebody before me, but I did. The paper consent may have been signed, honestly, a year ago by the family. So you're a new provider, you have to treat it as basically like a surgical procedure, and that you yourself obtain consent to continue that treatment. It would just help protect you. And the last thing you want to be involved with is any kind of lawsuit, and then not have any kind of, like, what if that paper consent that was done a year ago is now lost for some reason? This will protect you. So that's critical to put in your first HPI. The first note that you write on that patient is your basic history and physical, and that's where that informed consent little blurb should be. And I actually have a blurb that I kind of just copy and paste from note to note, but I do adjust it. So if the patient's non-coherent, I'll say I discussed it with the daughter, Emily, and she agreed. I make it very specific, so it takes an extra couple of minutes, but in the long run, should you ever end up in a lawsuit, this will save you so much pain. I promise you. I hope that none of you ever have to get involved in one, but I have personally, and this will absolutely help you. So take that extra little bit of time, and like what Bianca's going to go over here, defensive documentation is really critical. Anything that's on that paper, whether you did it or whether you didn't do it, will be looked over by someone trying to take you down. So that's what you have to think of it as. And they have expert witnesses. It could be me on the other side going, "Oh, Diana Lee, look at this. So you said that you did a full cranial nerve exam on this patient? That's interesting." And then you know, like, all the cranial nerves, for example, are fine. And then, later in your history, in your physical exam, you say the patient's completely, tunted, the eye, the right eye is, ptosis, that kind of stuff. So always try to make sure things match. It's super important. As you do it more and more, this becomes quicker and quicker, and then eventually becomes second nature. But attention to detail, especially that first history and physical, is critical. And we will kind of audit your notes from time to time. And that's not meant to get anybody in trouble. It's meant to kind of just help you so that you know what you're missing. And then, also sometimes there's really they'll say there's no such thing as over documentation. However, you can over document if you're stating incorrect facts, such as, we are not putting a stethoscope to these patients' hearts. So if you put on a cardiac exam, there's no murmurs, rumbles, and gallops, you better have actually put a stethoscope on there. For my cardiovascular exam, I'm more focused on there's no edema, there's no palpable pulses. That's usually my cardiovascular exam. I'm not listening to their heart per se. So just little things to keep in mind like that.
Yes. So, sorry. Let's see. So defensive documentation, like you mentioned, want to make sure that we're defending ourselves. We hate to be in that manner, like they're coming for us. But if the reality is especially in California, we're in a very litigious state. And I see all the time class action lawyers looking to sue nursing homes. And unfortunately, we kind of get pulled in by, guilt by association. When a lawyer pulls a subpoena for notes, they're pulling everybody's notes. Does that mean that we're the ones in trouble that did something wrong? No, but they're still going to scrutinize everything. So we want to just make sure that everything that we do is accurate. We're being defensive as possible in our documentation, just to cover ourselves. And also it does help the patient realistically. So want to be thorough and accurate, detailed notes, like you mentioned, being very comprehensive about it. You're going to be more comprehensive, of course, in your first one, but subsequent notes, we want to make sure that they are, addressing everything that you did and any changes of condition, any plans of care. You want to give details about the patient's condition, history, care provided, document the who, what, where, when, why, and how of every patient encounter. So if you have a situation where you went to the patient's house, you notice the dressing hasn't been changed for a week, and the wife or spouse or whoever is taking care of that patient, you have a conversation with them about the importance of dressing changes. You want to document that. That's going to cover you and everybody in the long run. You want to be consistent. You want to ensure that all entries are consistent with other records and follow a standard format. Consistency can be that you're consistent with your note. You can't have a stage 4 this week and then a stage 3 next week on the same wound, as we can't downstage. So you want to be consistent on that. You don't want to have it documented as a pressure injury for 5 weeks and then all of a sudden be a diabetic wound and then back to a pressure injury the following week. So you want to be consistent in those things. You want to use objective language. You want to avoid being subjective or using any vague terms. Anytime that we're vague or use subjective terms, that can be interpreted however they need it to be interpreted. So, we want to be very clear, concise, and objective. You also want to be timely. Document as soon as possible after the encounter to ensure accuracy and completeness. You could see anywhere between 10. We had some person see 82 patients in a day. That was crazy. She's a champion, but you can see anywhere between 10, 30 patients a day. If you're waiting until the end of the night to do all of your documentation, you're probably going to forget something. So I highly recommend you have a tablet, doing it in real time as much as you can, so that way you don't miss anything. Sometimes I forget what I had for lunch when somebody asked me during dinner time. So, I think it's very important just to be on time, timely, to be accurate. You also want to make sure that you include the date and time of each entry. That kind of seems unimportant, but it really is, especially if you're looking at maybe a graft application time or negative pressure. Some negative pressures have actually like run time. So if you put, hey, I went and saw patient Z, we put negative pressure at 10 a.m. on Monday. And then when you come back on Wednesday and that negative pressure maybe has a runtime of 2 hours, you're like, well, wait, I put it on this time. Why? What happened? Right? So those things are important. It can help find gaps or build gaps as well. Also, wounds progress quickly. So having an accurate time on that can help determine if something happens. So if you go today at 10 a.m., you document that you saw the patient, it was a stage 3, and then you come back, or the nurse comes that next day and now it's stage 4, they see bone and tendon, they're going to know, okay, well, something happened rapidly to progress. And then you can start looking into what happened. Were they not turned? Were they not repositioned or whatnot? Clarity and legibility. So when you're doing the shorthand note, we want to ensure that your handwriting is legible. We all know the jokes of doctors' handwriting. I mean, I know my handwriting, the more school I go to, the worse it gets. But it's important that it's legible. The worst thing that we can do is delay care because they can't read something that you're writing. So, trying to be as legible as possible. We want to avoid abbreviations that are not widely understood or commonly used. For instance, here you're going to see UGT and RGT. A nursing home is not going to know what that is. And I'm sure right now, as I'm saying it, most of you are like, what is that? I have no idea. That's something that we use internally, so I wouldn't recommend putting that in a note. And just to break it down, UGT is urgent G-tube and RGT is routine G-tube. So using an abbreviation like that is not going to work outside of our organization. So being mindful of those things. Of course, we know the typical ones, PRN, PO, that we learned in school. Those are appropriate to use, but anything else we shouldn't. We also want to document patient interactions, document discussions with the patient, including any information given, any questions asked, and the patient's responses, especially their understanding or not understanding of their plan of care. I know Dr. Rosing already mentioned this, but this is one thing that's really important: informed consent. Clearly document the informed consent discussions, including the risks, benefits, and alternatives of proposed treatments. And like you mentioned, documenting that the informed consent was obtained is vital. Because that document could be lost. They could say they never signed it, that it was, especially if it's a verbal. So documenting that is just a second layer of ensuring that we're doing everything that we can do to protect ourselves with the informed consent and that they are informed of it, especially when we're doing debridements. That's really important. We want to make sure that we're documenting or any questions asked. We want to explain to them that, hey, when we're doing a debridement, the wound may be a 4x4 today, but after the debridement, it can be a 5x5. It's not that the wound is getting bigger, and we're making it bigger for our fun, or just to keep the patient longer. It's debriding, it's getting bigger because there's underlying tissue that's not healthy, and we have to remove it in order for it to grow or to heal. Refusals and non-compliance. So we want to record any refusals of care or any non-compliance with recommended treatment, including the patient's stated reason. So if you have a patient that has a coccyx wound and they like to be up in the wheelchair for 8 to 10 hours a day, and we've discussed it with them, we've told them, why they shouldn't be up that long, why the importance of turning repositioning. We want to document those things. And if the patient says, oh yeah, I'm going to do it, we want to document that they understood that. If they say, no, I'm still sitting up, we want to document any additional interventions that we gave them. We want to inform the IDT team and saying, hey, patient B may not get better at the rate we want them to because they're refusing to get out of the wheelchair with the coccyx wound, whatever it is. And then they can also try some additional interventions, whether it be a modified chair, some cushions or whatnot. But we'll go into some of those things later. Clinical judgment and decision-making. So we also want to document our rationale for decisions. Document the reason behind clinical decisions, including differential diagnoses and rationale for chosen treatments. Especially when we're doing like a change of care, we want to say, we did XYZ dressing for 4 weeks. It wasn't healing, or the drainage increased. So I'm going to change it from this dressing to that dressing. So we want to make sure that we're documenting the rationale. So it's very clear why we change that plan of treatment, especially if we're changing the plan of treatment because it's ineffective. Take credit for that reassessment. So, patient wasn't healing. I decided to try another treatment to address that, non-healing factor. This is what I did. We also want to do any changes in condition. So any changes in the patient's condition and corresponding changes in the care plan, whether that's a positive change of condition or a negative change of condition. And maybe the patient came in non-ambulatory, was bedridden, and now, they've been on physical therapy and they're walking more. So that wound on their coccyx is healing faster. Now we're doing a different treatment because of that. So documenting those things is really important. It shows that every time you go in, you're not just treating the wound, that you're treating the whole patient according to their current situation. Collaboration and communication. So consultations and referrals. Document any consultations with specialists or referrals made, including the reasons and outcomes. So for instance, if you have a patient that is diabetic and their diabetes, you check their hemoglobin A1C or their finger sticks, and it's absolutely out of control. We actually want you to communicate that with their primary care physician. Hey, we need to do something. Maybe you need to change their insulin, or do we need a nutritional consult? Whatever those interventions that you do, we want to make sure that you're documenting that. And it's not just because we want to be, oh, look at what I did, but it also shows that I'm trying to do everything I can to ensure that this wound is healing. The reality is the wound isn't going to heal at the rate we want it to heal if their diabetes is out of control. So we need to do things to address it. Especially things are modifiable. Theoretically, if they're compliant, we can have modifiable factors in diabetes. So additionally, team communication, record communications with other healthcare team members, especially concerning significant changes in the patient's health or plan of care. This is going to be, when you're talking to them about them being non-compliant, or maybe they're a smoker, and you want to talk to the social worker at the facility about getting them some additional resources on smoking cessation. So document those things. Error correction, sometimes it happens. Of course, if it's handwritten, we just do the line, write error and our initial. We don't use whiteout or any correction fluid. Add any addendums. Additionally, you can add the addendum, writing the date that you wanted that addendum to be for. On our EMR system, obviously you don't have to do a line, but you can write an addendum, and you can write any modifications that need to be relevant to that one day. Dr. Rosing, you want to add anything on how to correct anything on the EMR?
Yeah, I usually, if there's something that needs to be corrected, I ask Jamela and her team to help out, because you don't want anything to be looked at as shady in any way. You can't go back and correct things after, say, a subpoena is made. So if you do want anything corrected, they can help you do that, and it'll timestamp everything. Just as an example, if you incorrectly documented something as a stage 3 pressure injury, and you want to change that to arterial because you just misdid it, that's fine. Have them do it. They'll timestamp it. And then usually I add something in the HPI as to, yeah, it was misdiagnosed as this, it's arterial as there was no pulses, and then we'll order Doppler or get an ABI to get something like that. But everything will be timestamped, so you never want to go back and change documentation without some sort of timestamp. So I usually do that through the QA department in Jamala.
Perfect. And if you have any questions when things like that happen, you can reach out to Jamela and team, myself, Dr. Rosing. We can help navigate you to those where you need to be.
Absolutely.
Legal and ethical considerations, of course, confidentiality. We want to ensure all documentation maintains patient confidentiality and complies with HIPAA regulations. So, we don't want to document that we had a meeting with the patient's daughter if we don't have consent to share that information from the patient, or that person isn't they're either their POA or their responsible party. So being mindful of that. We want to avoid opinions. So avoid personal opinions or derogatory comments about the patient or colleagues. Maybe you think that the patient has questionable hygiene needs, but they're not necessarily affecting their healing. If it, of course, is affecting their overall healing outcomes and whatnot, then yes, we can address it respectfully, but we don't want to just put opinions. I think that doctor's dumb. He didn't do this, right? So we don't want to do that. So we want to just make sure that everything is very concise, very accurate, very subjective. Or objective. So use of technology. So EMR and EHR systems. So a lot of times nursing homes will have their own, they do have their own EMRs. We have our own EMR, but sometimes they'll want you to log into theirs, which is fine. You'll be able to log in, look at your HMPs or anything that's for your patients. For us, we encourage the use of our EMR system on a regular basis in real time. We have Wound Ally. It helps to enhance accuracy, legibility, and accessibility of records. We are working on linking our Wound Ally with what's most commonly used in the industry at nursing homes. I think eventually we'll probably do the same with home health and hospice. But until then, you might be reviewing the notes that they have on their system. We don't encourage you to enter notes into their system. We want them in our system so you're not doing double work. They can upload our notes into their system manually right now. Eventually it'll be automated. We also have templates and checklists. So we're constantly adding templates and checklists to our EMR system to help ensure that all necessary information and documentation is there for specific things, especially like graphs. We want to make sure that you're checking all the boxes because there's a lot of documentation that goes into that. What are some other templates that we have in place right now, Dr. Rosing?
Templates, sorry. I was like responding to the Slack message.
Sorry. Some other templates that we have in Wound Ally right now.
Oh, there's multiple templates. There's ones for offloading, there's ones for vitamins and for different kinds of nutritional type wants. And I would encourage you to use them. And then you can almost, if you need to, sort of change the wording for your specific patient if need be. We will also have them for skin grafts, should you be doing those, as well as for Ultramist. And we're going to be making some for hospice patients. So all these things they're on there now, but we are adjusting some of them. So they are quite helpful. And when you do the EMR training, Jamila will go over those with you and make sure you kind of like know where they are and stuff like that. The EMR training is not difficult, but there are a lot of little nuances. So as you guys are doing it and kind of getting used to it, please feel free to reach out to Jamila, myself, Bianca, and we can kind of help out with that so that you can find everything. Because there's a lot that's on there that will make your guys' lives a lot easier and help with documentation, but you kind of need to know where it is. And the more you start using it, the better you will. Like I've been using it for over 2 years now, and I'm finding things now that I did not know were there that definitely help. So it takes a little bit of exploration on your part and then some questions should you have.
And one thing too that I want to talk about with the templates and checklists, the templates, we want they're editable, and we want to make sure that you're editing them as appropriate. We don't want you to, like I mentioned earlier, like these copy and paste type things. They're there as a tool to help ensure that you're covering all areas of documentation. But we need you to make them your own. So adding, for instance, the graft, when you're talking about wastage, we want you to put that in there. Wound is XYZ, there was X amount of wastage, and whatever you need to do to make it unique to that patient encounter is very important to make sure it doesn't just look like a copy and paste. So unavoidable wound. Now, almost every wound that you're going to hear me talk about, we could dance around it and make it an unavoidable wound. But the reality is that when we don't want to just be putting unavoidable wound if there is some avoidable type thing. So what is an unavoidable wound? So an unavoidable pressure injury is defined as those that develop even when the provider has already evaluated the individual's clinical condition and pressure injury risk factors. So that's going to be like your Braden scale, your Norton scale, your assessments, but are typically done within the nursing home upon admission. Defined and implemented interventions that are consistent with the individual's needs, goals, and recognized standards of practice. So that's going to be, we know that the patient has malnutrition, so they address that. We know that the patient has a history of wounds, so we went ahead and put them on a therapeutic mattress. All of those things. So we've already done these interventions, yet a wound still develops, right? That we've monitored and evaluated the impact of the interventions, and that we've revised the approaches as appropriate. So we have a patient, they have a history of wounds, so we put them on a pressure reducing mattress, but now we notice they have some redness. So what do we do at that point? So that means we would need to modify that intervention to maybe a low air loss mattress rather than just a pressure reducing mattress, and say that we revise that approach and now the patient still developed a wound. That would be considered unavoidable. It can't just be that we put in one intervention and we didn't modify it as we noticed things were happening, right? So that's really what makes it unavoidable, that we've put in interventions, we've modified interventions, and the wound still came. So some unavoidable wound cause, advanced age. We know most of our pressure injuries are going to be in the geriatric community because there are skin changes. Aging skin becomes thinner, less elastic, and is more prone to injury. We all see the older people outside that, they have all these bruises all over their arms, there's skin tears everywhere. They, I know my grandfather would hit the doorknob barely and there would be a skin tear. So we all know that. Additionally, they have reduced mobility. Older adults may have decreased mobility, making them more susceptible to pressure injuries as they're not able to turn and reposition in an appropriate time. There could be severe comorbidities. People with diabetes, poor circulation, and neuropathy obviously increase the risk of wounds. That's why we always encourage people with diabetes, especially when they get to the neuropathy level, that they're checking their feet multiple times throughout a day. Peripheral artery disease, reducing that blood flow to the extremity can lead to tissue ischemia and ulceration. Chronic heart failure, having all that fluid retention and poor circulation also compromises skin integrity. Immobility. So patients with paralysis, patients with spinal cord injuries or strokes may be unable to move, increasing pressure on certain areas. They become reliant on everybody else to turn and reposition. So if they don't have that support, or the people aren't turning them as much as often as they could, or maybe they're being non-compliant, they're going to have an increased risk for that. Critical injury or critical illnesses, like I mentioned earlier, ICU patients may become immobile due to sedation, mechanical ventilation, and other illnesses. And we know a lot of times in the acute care world, they're not really looking at the skin, they're not turning, repositioning, they're just trying to keep that patient alive and stabilize them and get them to a point where they can go to a lower care. Nutritional deficiencies, of course, we know malnutrition, inadequate protein and caloric intake can impair wound healing and increase susceptibility to injuries, especially pressure. Dehydration, lack of adequate fluids can make skin prone to breakdown. If they have incontinence, so anytime there's a prolonged exposure to urine or feces, that can cause skin maceration and increase the risk of pressure injuries. Having severe edema, the swelling and the excess fluid in tissues can compromise the integrity of the skin. It decreases the blood supply to those areas and leads to wounds. Medical devices. So I know everybody kind of seen really with the pandemic. We talked about these pre-pandemic, but it's really since the pandemic, we really started addressing medical device related pressure injuries. So prolonged use of any medical device, oxygen masks, catheters, those can all cause pressure injuries. But the important thing to note is, okay, so yes, I have a catheter, for whatever reason. The reason I'm going to get a pressure injury mainly on a certain area related to that catheter is because I'm relying on it. So there's nursing interventions and human interventions that can be done to prevent it on certain medical devices, right? So I feel like these are all kind of questionable on how unavoidable they are. Oxygen masks are what were the interventions that we did, right? So those things need to be documented to really justify that it was unavoidable. Braces and splints. So these are things that I really think can be looked at as a true unavoidable. Everything else is kind of questionable without additional documentation supporting the interventions were made to address some of the causative factors, right? Because like if you have a nasal cannula and you know that the patient is getting injuries behind their ears, well, what do? Do we change it to a mask? Do we put cushion here? What are we doing? Are we making it a little lighter? What are we doing and documenting as an intervention to help decrease or mitigate that risk, right? When it comes to braces or splints or any orthopedic devices, especially when it comes like traction and things like that, those can be truly unavoidable. And I know Dr. Rosing will probably want to chime in here. There's certain things that we can't remove. If they have, traction, they're not going to be able to move. If they have a cast on and there's some pressure injury going on inside the cast, we're not able to go and do interventions. We may not even know what's going on because we can't see it. We can't assess it. And a lot of times these things, splints and some of the braces can be removable, but some of them that are not removable are asked not to be removed by the orthopedic surgeon or whatnot. Those can be considered unavoidable. Anything you want to add there, Dr. Rosing?
Nope, all good.
Okay. As far as cognitive impairment, of course, patients with dementia and any type of cognitive impairment. They may be unable to communicate discomfort or pain, leading to unnoticed pressure injuries. If they have delirium, so any acute confusion can result in decreased mobility and increased risk of injury. And they may not have the cognition at that point to even understand that they may be having some sort of condition. End of life care. So, when a patient's on hospice, it could be having multiple organ failure in the terminal phase of life, resulting in decreased blood flow and skin breakdown. They can have cachexia, severe weight loss and muscle wasting can reduce the padding over the bony prominences, increasing pressure injury risk. It's just really important that we're documenting all of the interventions that we're doing, especially when it comes to cachexia, turning, repositioning, low air loss mattresses, additional padding, whatever we're doing to mitigate that risk. And if they still get a pressure injury, then that makes it unavoidable. Poor circulation, so any venous insufficiency, arterial insufficiency, those can all lead to skin breakdown. So we want to make sure that we're addressing all of those things. I know Dr. Rosing will definitely stress the importance of doing an ABI Doppler or a pulse exam and documenting that thoroughly, because those that documentation is very imperative to part of the not just the unavoidable part, but the defensive documentation and the understanding of why this patient is developing these wounds. So additionally, non-compliance. So we have patients that are non-compliant. I'm sure we've all run into them, but they can be non-compliant for multiple reasons. It may not just be because they're difficult, right? There could be other situations that are addressable and modifiable that we can take care of to make them less non-compliant. So do they have pain during treatment? And is it general pain? Or do they have depression? Is there a psychiatric diagnosis? Is it just flat out refusal of care, or is it lack of support? And assessing these situations and is very important to your plan of care and how to do your appropriate interventions. So how to address non-compliance? So referring out to specialists, right? So you go to your patient's home and you see a stack of Oreos and Snickers and they're diabetic, right, at their bedside, and they're over here eating a corn dog. Those are things that you're probably going to want to address to the specialist, to their primary care physician, to a nutritionist, to their family, because obviously their blood sugars are going to be most likely unmanageable unless they have a sliding scale that they're just living off of, right? So those are things you want to address with the primary care physician. You want to document any education that you've given to them about that. Pain management. So, where is the pain first, right? Is it pain in the wound? What can we do? Do we need to do ultramist? Do we need to not do debridement? Do we need to pre-medicate? Things like that are very important to consider, assess, and make the appropriate interventions for those. If it's general body pain, right? Well, we can pre-medicate, right? As we're turning repositioning, right? So some people, maybe the wound is on their coccyx and we're putting them on their side and they're in severe pain that entire time. So pre-medicating. In the event that every intervention that you have tried regarding pain management doesn't work, then we want you to go ahead and refer out to pain management as appropriate. We want to make sure that we're addressing everything appropriately. Psychiatry, we want to make sure that if they have a psychiatric diagnosis, maybe they have depression, maybe they have I don't know what other situation, bipolar, any of those type of situations that are inhibiting them from maybe having a failure to thrive, or maybe just being non-compliant because they're in a period of hysteria. You want to refer them out to psychiatry for either modification of their medications or any maybe new medications that need to be added. Also social services. So in the event that a patient has lack of support in the home environment, maybe they don't have financial means, maybe they don't have a good support system at home, a husband, a wife to take care of them, or maybe a lot of times you'll see a married couple and the wife means well, but she just can't turn and reposition the husband appropriately, right? So you want to do any interventions that are appropriate. Talk to the social worker and say, hey, maybe they need a in-home support caregiver, maybe they need a bath nurse, whatever those things are. Additionally, maybe they don't have money. In the event that they don't have money and they can't maybe afford the appropriate nutrition, you want to also refer out to social services. Maybe there's a Meal on Wheels, or maybe they need to be put in a nursing home until they're able to provide for themselves. So different things like that. We also want to document the patient's noncompliance. So document your explanation of the risks and benefits to noncompliance to the patient or caregiver. So, for instance, if they're a smoker, we want to document the smoking cessation communication, what the benefit is to quitting smoking as far as their wound healing, and any risks that come with not quitting smoking. That, hey, your wound may not heal, it may progress, it may take XYZ, and you're going to have to see my face for the next year if you don't quit smoking because you're never going to heal. Whatever you need to do, but you want to document that. Documenting all of the interventions is very important. This kind of goes back to litigation. Just because you documented the patient is eating a pack of Snickers every day and their blood sugar's out of control, well, what did you do about it, right? Well, you knew that that was a problem. You knew that that patient was having those issues. What did you do about it? So you want to document those interventions. Document any referrals out, pain management, psychiatry, and then address any noncompliance issues with the IDT team to collaboratively identify the appropriate plan of care. Especially in nursing homes, they do have meetings pretty much weekly or every day about certain patients that have issues. Talk to the IDT, say, hey, John Doe is doing XYZ, what can we do? So they can also come up with some plan of care, but you also want to document that you did address it to them. So it's not just you in a silo working on this yourself. Any questions on that? All right, so going into malnutrition. So when a patient has malnutrition, ensure proper protein orders are in place, as well as reviewing and collaborating with the dietitian as appropriate to ensure all nutritional interventions are in place and the appropriate vitamins and supplements are ordered. This is something we definitely want to see documented too. Dr. Rosing and I did some random note reviews, and we noticed a lot of patients will have malnutrition diagnosis, but there's no documentation supporting that we reviewed the dietitian's notes, that we reviewed that they're getting adequate protein, that we reviewed any supplements that were being added. So that's really important because that's part of our comprehensive plan of care. If we have a patient with malnutrition and they're not drinking their protein supplements, well, we're going to continue to have some problems healing, and then we need to address that in a different way, or we need to figure out a way to get them to have their protein. So making sure that you're addressing that. Also documenting the review of dietitian recommendations are necessary, and they do demonstrate that comprehensive assessment of the patient. So if you go in, patient has malnutrition, and you review that dietitian's notes. And in nursing homes, you'll pretty much always have access to the notes, at least by your second visit. I believe the regulation is within 24 or 48 hours, they have to have a nutritional assessment done by a dietitian in a nursing home. So that will be readily available for you. So you can just document reviews, dietitian's notes, she implemented X amount of protein per day, this and that, right? So make sure you're documenting that. End of life documentation and care. So I mentioned this a little bit earlier. So hospice patients or palliative care patients, it's not as straightforward as it used to be. Hospice patients now aren't the hospice patients of before, where they're actively dying, where they just want conservative care to be kept comfortable, to be kept pain-free. A lot of times now you're going to find situations where the patients maybe even still be a full code. The family still wants aggressive treatment. So it's really important when documenting wound care for end-of-life patients that you take into account the family and patient expectations when you're deciding that plan of care. Like I mentioned, some patients don't want conservative treatment, even though they're receiving end-of-life care. I know a lot of patients are on end-of-life care because they need additional support at home that maybe their managed care isn't putting them on, and they have a qualifying diagnosis, so they take advantage of that for a little bit. Although a traditional hospice patient will be typically conservative, you want to keep the wound clean, odor-free, free of infection, and just keep that patient comfortable and out of pain. That's typical, but like I mentioned, upon your assessment, that patient may be wanting a little bit more aggressive treatments to where you're doing debridements, you're adding in maybe a graft, maybe you're doing ultramist. So, you need to really be comprehensive on these, and you want to document any conversations with the family and hospice agency when determining that plan of care. Additionally, you want to be realistic with the family. If the family is like, I want aggressive treatment, I want this wound to heal, but this patient is malnourished, they have, stage 4, maybe renal disease, they're not going to dialysis anymore, and there's just nothing you can do. We want to be realistic with them also, and not just do this aggressive plan of care if it doesn't make sense. So we still want you to be a provider, but we want to listen to them, but also be honest. So if there's absolutely no way that any aggressive wound care is going to help, communicate that, document that. In the event that you think that the wound could potentially heal, and maybe the family just doesn't want them to pass away with a wound, go for it, right? So that's where it's kind of a little bit not as straightforward as you would think with hospice patients. We also want to document any medications that inhibit or slow wound healing. Here's just a few. So anticoagulants do have the potential to slow wound healing, anti-inflammatory medications, immunosuppressant drugs, corticosteroids, metformin. So we want to document the usage of any of those medications. It's imperative, as it may assist in explaining why the wound isn't progressing in the healing form that they may want or we may have anticipated because of these medications. Additionally, we don't want to go and discontinue any medications just for the sake of wound healing if they're absolutely needed. So infection. So we want to document any presence of infection and the current plan of treatment. One thing that is important in your HPI, if you have multiple wounds and you have one wound with an infection and every other wound happens to not be infected, you want to make sure that you're very clear in that HPI of what wound is infected specifically. So then it's very clear that it's a specific wound, not all of the wounds. That helps for different reasons. Recently, we were reviewing a chart. A patient had, I think, 4 wounds. One of the wounds was infected, but the patient also had a graft. So we were like, well, wait, is the infection on the graft wound? And so we had to kind of go through a lot of the documentation. It was there in that specific wound, but if they would have put it up in the top, it would have been a little bit easier for anybody who's looking. So just keep that in mind to always specify which wound has the infection if there's multiple wounds. And in the event an infection is suspected, document the order and retrieval of a wound culture and results as they are completed, as well as any new medication or wound care interventions that may occur to the culture results. So if you added some oral medication, some topical medication, you want to make sure you're documenting that to show that, hey, we suspected it, this is what we did, and this is the new plan of treatment. Smoking. So smoking is something that we probably need to document smoking cessation with each visit. We want to document your patient's current and past smoking status, as it does directly affect wound healing. And if a patient is a current smoker, document that smoking cessation counseling with each visit. If they do need Nicorette or any type of I think Wellbutrin is sometimes used for smoking cessation. I would collaborate with the primary care physician on that, but make sure that you're also addressing to the smoker, like, hey, your wound healing is not going to progress in the manner that in which we hope because you're smoking. So explaining that, documenting that, and then also document the encouragement of smoking cessation. Illicit drug use. We also want to document any illicit drug use, specify the type of illicit drug use, counsel the patient on the risks associated with that illicit drug use and the benefits of stopping it, and refer out to social services for additional resources to assist in the stopping of it, and document that referral. And now socioeconomic consideration. So proper assessment of the patient's living situation, support systems, and economic status. They're all very important when establishing the appropriate plan of care. We don't want to go and do daily dressings on a patient that maybe doesn't have somebody there to change their dressings every day, and they're there by themselves. And maybe it's a wound where they can't necessarily do it themselves. Additionally, you want to look at when you're ordering, say, a wound vac, do they have the support system there to change it 3 times a week and to monitor it? If they don't, those are something that I wouldn't encourage you to do. So making sure that you're really assessing the capabilities and the support system you have or they have when you're ordering and your plan of, when you're ordering and making your plan of care. You also want to document any socioeconomic, your assessment and any referrals out for additional support, such as to a higher level of care, social services for maybe in-home support services, maybe they need Meals on Wheels. So anything that you are recommending or referring out, you want to make sure you're documenting. Vascular intervention. So this is very important. So you want to document the completion of the ABI Doppler, or we may have a new machine coming out soon called QuantaFlow. You want to document that in your notes. Additionally, your pulse exam, whenever there's any type of vascular lower extremity wound, should be documented. You want to document any previously vascular assessments in your note. You want to refer out to vascular for any abnormal Doppler results or failure to complete ABI Doppler due to absence of pedal pulses. Anything you want to add here, Dr. Rosing? I know this is one.
No, I'll get into it when we do the next section there.
All right, perfect. Family and caregiver education provided. So you want to document the plan of care, or when providing the plan of care to the patient caregiver, you want to ensure that you document the communication with them and that they understand that plan of care. If there's any deficit in understanding what to do, you want to communicate that with the IDT for appropriate collaboration. So, you know, maybe you go and you explain to them they need this dressing changed every day, or they need to be turned every 2 hours. And they're like, I don't know, I can't do it, or I don't understand. You want to reach out, you want to document that, hey, they didn't have an understanding, or they stated they couldn't do the 2-hour repositioning, referred to IDT for, you know, external support. Also, when in doubt, document. Documentation really is our end all be all. So making sure that you're documenting everything is very, very, very important. Any questions? You guys good? You guys want to take a break? We want to power through. It's been 2 hours, so I know it's been a lot. You guys want to take like a 10-minute break and come back, or are we good to go? 10-minute break? Thumbs up for 10-minute break, thumbs down for staying. Staying. Okay. We're going to go into complications. So complications is going to have a lot of the stuff that I just went over, just kind of building on it. So complications in wound healing can be, but are not limited to, refusal of care, pain, vascular referrals needed, a need for a surgical intervention, or uncontrolled diabetes. Refusal of care. So I went into this earlier. Like I said, some things I beat like a dead horse because they're very, very important. So is the patient refusing care due to an underlying issue? Is it pain? Is it depression or mental health issues? Is it because they have a lack of support and don't want to, a lot of times maybe they don't want to say, I don't have help at home, because they don't want to leave their home, right? Or they have unmanaged diabetes, whether it be for a lack of education on how to manage their diabetes, or whether it be just because, hey, I only live once and I'm eating the Snickers, I don't care. And what can you do to address the refusal of care? So, referring out to the primary care physician, pain management, psychiatry as appropriate, maybe a dietitian, collaborate with the IDT to address support issues and plan of care, and document refusal of care and any interventions taken to address the refusal of care. Pain. So, I always recommend, if this is part of kind of when you call and you give them an ETA, they know you're coming, so they can pre-medicate if they know they're going to have pain with this dressing change. So, take it, take the medication before so you can decrease that amount. Avoid sharp debridement if painful. You can use Ultramist debridement, or you can use something like Santal if they qualify for that. Refer out to pain management for uncontrollable pain. If everything that you've done, if they've taken, pre-medicated and you modified your debridement and they're still having pain, they may be appropriate to send out for pain management. You want to recommend frequent turning or repositioning. We know the longer we sit in one position, the more pain that somebody has as their joints become stiff. So, and then when you go to turn them to do their dressing, now they're all stiff, and now it hurts even more because they've been in that position for an extended period of time. You also want to encourage the use of adapted devices to provide additional comfort, whether that be additional pillows, a wedge, whatever that may be, to increase their comfort levels. Vascular deficiency. So we want to make sure we're completing an ABI Doppler test or ordering a ultrasound, or reviewing the chart for previous results. So a lot of times if you're in a nursing home and they've had this wound for a while, they come from a hospital, they may already have a vascular assessment in place. So rather than having to order a new one, you can just review the chart and see if there is one. If there is one, then you just document the review, blah, 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 follow, and then you diagnose the wound based on that, and you make your plan of care based on those outcomes. You want to refer to any vascular provider, though, for any deficiencies identified if they're not already under care of one. And you want to document the vascular deficiencies, and you want to ensure that the treatment orders are appropriate for that. You don't want to do a pressure injury type protocol on a wound that's not a pressure injury, as it's not going to be as effective. Surgical intervention, this doesn't happen very often, but it does happen sometimes, right? You may have to, send a patient out for an amputation. So wounds requiring surgical interventions, they will need to be referred out for advanced treatment such as flaps or anything that's requiring general anesthesia, which cannot be safely bedside. I know everybody has a different comfort level. I know a lot of our providers that are surgeons are more inclined to do something a little bit more aggressive than maybe somebody who hasn't worked in an OR for years. But when in doubt, consult your supervising provider or Dr. Rosing and see what is appropriate, and if it is something that we can do safely bedside, or something they can maybe assist you with, or if they actually do need to go out. Of course, limb salvage is very important to us here. We do want to try to save limbs, but in the event that there's just everything we've done, every intervention, we may have to send them out for an amputation.
Yeah, for anybody who there's always the surgical emergencies that you all might see. And any cold foot, for example, that has to go out immediately. And then sometimes wounds will be too far gone for us to do any kind of bedside treatment. It's going to be actually helpful. Those are kind of hard calls to make in the beginning, but I mean, I've definitely had to send patients out for actual surgical treatment before. So if there is any question, get in contact with your supervising provider or myself. I'll help guide you there. But yeah, any kind of cold foot, something like that, that's an emergency that needs to go immediately to the emergency room. And it's a little different if that's a hospice patient. If that's a hospice patient, that's a much different thing, and you need to kind of discuss that with the family. But if they're non-hospice patients, those need to be transferred. And then, sometimes you see surgery. Like I've seen a wound that went from 5 by 5, and the next week it was 30 by 30 with a necrotizing soft tissue infection. And that's something that we can't do. So you do need to pull the trigger. I know we're there to try to prevent patients from going to the hospital, but sometimes we're also there to be the eyes that go no, this actually needs to be in the hospital now. So, you'll get used to it. It is fairly rare, but when it does happen, don't be scared to send a patient to the hospital.
And when in doubt, you can always ask your supervising provider or us, and we can help navigate that with you. So uncontrolled diabetes, address the uncontrolled diabetes in documentation, outlining that the healing process may be slowed or inhibited. You want to refer out to the PCP for reassessment of current diabetic medication orders. And you want to collaborate with the IDT to ensure the patient is receiving the correct dietary accommodations. Now, in a nursing home, they're going to have, it's going to be a little bit, you're going to have less occurrences of them not being on the appropriate diet, right? They have somebody making their 3 meals a day. They're going to be on their 1800 ADA or 1500 ADA. And unless their family is bringing in a bunch of snacks for them, it's usually a little bit better controlled, right? They have a nurse managing their medications, things like that. So, but when they're in a home environment, that's when things may get a little questionable. So, you want to talk to the social worker, and maybe that, they can arrange some sort of meal service, or maybe the family just needs education on how to provide or even make the meals as appropriate. They may not understand that, a bread is a sugar, right? So those are definitely things you want to address. Additionally, when you're looking at uncontrolled diabetes, it's really important to know that although the hemoglobin A1C is a really great standard of where they're at long-term as far as their as far as their management, we still need to look at their finger sticks too, just because if that hemoglobin A1C is 3 months ago and they added some new medications, and maybe they were put on Ozempic. I know that's the favorite right now, but it is effective, right? So maybe that hemoglobin A1C was a 10 3 months ago, but now you look at their finger sticks for the last 2 months since that medication was added, and they just haven't had a new hemoglobin A1C and they're under control. Or maybe they had a hemoglobin A1C of 4 or 5 2 months ago, and now you notice that their blood sugar sticks are 300-400 every time. So just using actual time are, real-time information in conjunction with some of the tests that aren't as frequently done. It's very important. Infection control. This one's pretty quick. Infection control and prevention in the mobile wound care environment is crucial to ensure patient safety and promote healing. Here are some strategies and some best practices. There's some things that we don't necessarily think of in a traditional setting that are unique to mobile wound care. So of course, hand washing, number one. Frequent hand washing using soap and water and alcohol-based hand sanitizers before and after patient contact. You always want to wash hands before and after donning gloves, and wash hands in between patients. I know in some home environments, I've witnessed when I've shadowed people not washing their hands as frequently as they should and not even using hand sanitizers. And it's really important that, I know sometimes we don't want to be like, hey, can I use your sink, because maybe the family's rushed or you just don't want to feel intrusive, but it's very important for your safety, the safety of the patient, and the safety of your subsequent patients. Glove use. So we want to wear disposable gloves during wound care procedures and change them in between wound sites. We also don't want to carry loose gloves in our pockets. I mean, I've seen people do it, and then there's a little ball of lint on the end, and now that lint is in the wound, and we're just closing that up, and it's just a mess. So, if you don't feel like bringing the full box into patients' homes, put some in a plastic baggie and put that plastic baggie in your pocket, so at least protects it from outside sources. You want to ensure the proper disposal of gloves. Please don't put the gloves back in your pocket. We want to throw them away in a trash can. And we also don't want a double glove. Aseptic and clean technique. So of course we want to use clean gloves, dressings, and instruments. And we want to ensure that all supplies are properly stored to maintain clean status. We also want to have a clean work area. Now, when you're in a nursing home, you're typically working from their treatment cart, which is, they wipe it down and everything's on there. It's clean. However, when you're in the home environment, you may be using their bedside table. You could be using part of their bed to put some of the supplies. So you want to make sure that if it is a hard surface, you wipe it down. So bring some wipes with you to make sure that it's clean when you are using it. If you are putting some of the supplies on the bed, you might want to put like a chuck or a plastic bag down to make sure that you're not contaminating anything. You also want to ensure that your clean and dirty equipment is separated, such as your sharps container. You want to make sure that that's not in an area next to all of your clean dressings. You also do not want to touch your clean supplies and equipment with soiled or gloved hands. So, for instance, if you do have an ultramist machine, that machine is brought into each patient's home. So you want to make sure that you aren't like going and touching the wound and then going and fumbling with the buttons, right? That's where you can have your field assistant turn it off and on, or take off your gloves and then touch it. And then you also want to wipe that down before going to the next patient's home. So PPE, masks, and gowns. So use masks and gowns if there's a risk of splashing or any aerolization of bodily fluids. Eye protection. So you want to use goggles or face shield to protect against splashes when appropriate. We don't see a lot of those type of wounds. You're not really doing a ton of lancing of boils or anything that could potentially splash at you. But if you are doing maybe ultramist where there is a mist, you want to wear something appropriate. You also want to follow facility protocols as indicated. So if they have a patient that is, has MRSA, and you want to follow whatever they're telling you to wear in that wound. So making sure that you're not putting them at risk for any citation. So if it's full gown, mask, gloves, do it. If it's just masks and gloves, then follow that. Even if you don't feel that it's necessary because you're just touching the dressing and you're not going to, and that wound isn't infected, still follow their protocols. Environment and equipment, like I mentioned earlier, you want to make sure you're disinfecting equipment, anything that could be brought into multiple patients' homes, that you're cleaning and disinfecting it between patients. And your mobile unit, so your vehicle. So maintain cleanliness of the mobile unit as far as making sure you're wiping everything down on the surfaces. As you're getting in and out from, different places, as careful as you can be. Sometimes we're, leaning up against a curtain that could have some stuff on it. Maybe you leaned up against the bed. I know I don't want to bring that home to my family. I'm sure you don't want to bring it home to your family. And because you are getting in the car, I would recommend wiping it down as frequently as possible, but definitely before you, when you get home. Weights disposal, so sharps disposal. So you use puncture resistant containers for needles and other sharp instruments, such as your curettes. I don't know. I believe Precious went over everything yesterday on how you get your sharps containers. We do supply those for you. Joanna is who does all of the supplies. So if you notice your sharps container is getting a little full, just send her a message, say, hey, can you schedule this for pickup and schedule a delivery for new ones. So she'll be able to do that for you. You want to keep your sharp container in a different area from clean supplies. You don't want to keep it with all of your other dressings. Medical waste, so you want to ensure all soiled and contaminated equipment and materials are kept separate from clean and sterile items. And you also want to dispose of contaminated dressings and other waste according to with regulations. And that's really when it happens in nursing homes, because they may have a red trash can for anything that has bodily fluid, where you're at home, that might not be applicable. You could just throw it in their trash can. And of course, you want to wash your hands after disposing of soiled equipment and materials. This is pressure reducing devices. So this is some interventions that we commonly make for our patients with pressure injuries. So tissue load management refers to distribution of pressure, friction, and shear on tissue. Support surface. So a support surface is defined as a specialized device designed to redistribute pressure on a patient. So management of tissue load, microclimate management, and other therapeutic functions. So choosing the correct surface can get a little confusing, especially if you don't know what you're looking for, and you kind of start with terminology. So there's old terminology and new terminology, and the reality is that they're both used. So knowing both of them is important. So there's static, which means that it's just kept at a certain level. It's not alternating. And I'll kind of go into that a little bit later. Dynamic is really where it's alternating pressure or low air loss, pressure relief, and pressure reduction. And then there's non-powered, powered, and pressure redistribution is kind of the new names that they're using. I see them all used. I still see static used very, very frequently. So just to kind of be aware of those terms because they're all very relevant. So new terminology for pressure redistribution is the ability of a surface to distribute the load over the contact area. So the therapeutic benefit of preventing or managing pressure injury. So that can be a foam mattress that has pressure redistribution. It can be a low air loss. It can be powered or non-powered. So it's kind of a broad category. There's active and reactive to define the ability of the surface to adjust to load distribution in response to the load being applied. So that's going to be more of your like low air loss mattresses, right? Where you put a patient on it and it will typically the heavier area will add extra air to give a little bit more support. So it's not bottoming out versus one that's maybe a foam. And if there's heavier weight, that foam isn't going to activate to add extra foam to the area, right? So reactive support surfaces could be a mattress or overlay, powered or non-powered, adjust the load when the patient is on the surface. It does lower the contact pressure with immersion or envelopment, foam, air, or both. There is some gel-filled and low air loss support surfaces. So this one I go over, but you're really never going to see this in a nursing home or in the home care environment. I mean, maybe 1 in 10,000. This is a very expensive bed. It's typically like the dolphin bed. It is an air fluidized bed. And essentially it has ceramic silicone beads that become fluidized as they warm. And it really just provides like a floating area for this patient. Might see it commonly in flat patients or in burn patients, but because we're not really taking care of them in that acute phase, you don't really see it. Most nursing homes aren't going to pay for those beds. I want to say the last time I checked, which is many, many years ago, they were like $5,000 a day or something like that. They're ridiculously priced. So you're not really going to see it, but you may see notes that they've had that in the hospital before. So some active support surfaces example. So powered surface adjusts the load distribution with or without the load applied, removes contact pressure over time. This is more for high risk patients, and it's programmable for turning degree, duration, and frequency. Alternating pressure. So this is very commonly used in a nursing home. Essentially, you see these cells here, right here. One will inflate and the other will deflate. And you can set that at different time intervals, 10, 15, 20, 30 minutes. And what happens is as these ones are inflated, so these ones will stay inflated for 15 minutes. Then after 15 minutes, those ones will now deflate and the ones that were deflated will now inflate, subsequently reducing that pressure for prolonged periods on the patient. This one is probably by far my favorite mattress, especially for patients that are in a subacute. Maybe they have a ventral trach. Maybe they are in a home environment and they don't really have somebody to turn and reposition them every 2 hours, or even in a nursing home. It's really hard to turn and reposition somebody every 2 hours. This one rotates the patient automatically from side to side or side back side at the duration that you choose. You can actually also choose to not have it, say the patient had a hip surgery and they can't go on their left hip, you can have it just rotate from the back and the right. It can be 15, 20, 30, 45-minute intervals. This doesn't take the place of repositioning. So if you put the patient in the position that this gentleman in this picture is in, he is going to stay in that position. He is just going to offload that weight because the mattress is going to move to offload that weight from side to side. Low air loss mattresses, these are also very commonly used. You'll actually see a lot of mattresses actually have both the low air loss and alternating pressure components built within them. Essentially, the low air loss mattress is kind of like an air hockey table, for lack of a better description. There is air that flows out through the mattress to the skin, and that helps the microclimate, keeping the patient's skin from being very moist. The biggest issue that I find in nursing homes is a lot of times they'll use way too many covering materials on top of the mattress. Because the mattress has air that blows through it, we need that air to touch the patient to keep them dry. So really the only thing you should have on that is maybe a draw sheet, a air permeable chuck, and that's really it. You don't want a fitted sheet. You don't want multiple draw sheets. You don't want non-breathable chuck on there, because you're kind of doing the opposite. You're now preventing that air from flowing through it. But you will see, you'll go into a nursing home and there'll be a low air loss, lo and behold, with a fitted sheet, a draw sheet, 2 chucks, and a patient in a diaper. And you're like, this really isn't working. We're able to provide education for that. But I always recommend, if you do see a patient that is on a low air loss and you see all those things, make that a learning moment and say, hey, the patient isn't receiving any of the therapeutic value from this. So I just really, if they're incontinent, which most of them are, I can understand why they want a chuck on there. Just make sure that they're using a breathable chuck. Of course, we want to have the draw sheets for returning repositioning safely, but other than that, they shouldn't have more than that. So here's some support surface terminology. So mattress overlay is really just what you see here. It's a little overlay that goes on top, kind of like back in the day we used to have like the egg crates. These are helpful, but they're not going to help anybody with a stage 3 or 4, because they're very thin. They're maybe 3 inches, so you're not going to be offloading as much as you would if you did a full mattress. But these are, if that's all they have, it's still something's better than nothing. But preferably you would do a whole mattress. So bottoming out. So when you're in these nursing homes, there is a variety of mattresses that they use, and not all of them use the most expensive, high quality mattresses that are available. And you may have ones that have a knob, and these knobs will be set by you. You're going to manually set them, right? Unfortunately, that is something that you're going to have to do on your own. And how to test for bottoming out is you're going to set it to, it goes firmer and softer. And you're going to put your hand between the frame of the bed and the mattress. And if you can feel their bottom or any of the heavier areas, you're going to know you need to increase that a little bit firmer. If it's too firm, then you're kind of putting them on a rock. If it's too soft, you're putting them on the bed frame, and it's kind of counterintuitive. So you want to check for bottoming out in multiple areas. There should be a couple inches of in between that mattress and the bed frame and their body. So you want to assess on various areas, typically, obviously, the bottom area, any of the shoulders, and it also depends on the patient, right? If the patient has a very heavy lower body, you might want to check different spots on the lower body and vice versa. Additionally, when you're dealing with mattresses that have the turn knob, I always recommend that you get a little chart flag, and once you find that therapeutic level, that you tape that there and you put, therapeutic level, and then you just, especially if they're a home patient, you can explain to them like, hey, this is a therapeutic level, you should keep it at this. Nursing homes, they should already understand that, but also explain that to them. If they can't manage it, then I definitely would recommend that you talk to them about getting a better type of mattress, one that's more electronic, because if they're going to be bottoming out, or if it's going to be really, really hard, then you're just actually adding insult to injury, and they would be better off on a foam mattress. So considerations, additionally, when you're ordering support surfaces, you want to manage the heels independently from the surface. So if they have a pressure injury on their foot, the low air loss mattress isn't going to be everything that you're going to do for that. You're going to want to use heel protectors, foot cradles, and you're going to want to float those heels above the surface as well. So putting pillows or wedges underneath their legs. So offloading the diabetic foot. So you want to use pillows and wedges. I know wedges are going to be more uncommon to find in a nursing home. You could, if you're in a home environment, encourage the family to purchase them, but most likely we're going to be using pillows. So you're going to want to use pillows for everything, but for turning repositioning when it comes to pressure redistribution, when you're, turning a patient on their right side, you're going to want to put pillows on their side to keep them into that area. You're going to want to put pillows in between their knees where there's bony prominences, or their ankles. So using pillows when you're repositioning and offloading patients is a vital component in efficacy. And it also improves their comfort, and it also gives them some pain relief. I mean, I'm sure we all I know I sleep with like 4 pillows, and one's for my legs and one's for my foot and, my head. So they're the same way. So it also helps provide support. A lot of these patients can't necessarily support themselves on their side. So they definitely need that to help support them. It also promotes proper body alignment. So it keeps them in those positions. Like I mentioned earlier, it allows for spinal alignment, joint positioning, and it helps improve their circulation if you're putting pillows under their legs, things like that. It also facilitates mobility. It can help transfer them because they'll be already kind of pushed to the side, and will help them be more to the right side if they're transferring out on the right side. Examples of use, so you can use a pillow or a wedge to keep them at a higher position. You can use it for the heel offloading or putting them into the Fowler's position. So types of pillows and wedges. So standard pillows are probably what's most commonly used. That's what we're going to find in nursing homes and whatnot. Foam wedges. If you can get the family to buy those, that's great. It will make things a little bit easier for them and for you. Specialty cushions, you'll find those like for your heel protectors and lumbar support. But most commonly, you're going to really encourage the use of pillows. Wheelchair cushions, of course, this is very important, especially for those patients that want to be up and out and about. There's a few different types of wheelchair cushions. I'll go into those. So there's air cushions. This is probably what you're going to see, air and hybrid foam. These are the ones you're going to see the most frequently. They're lightweight, they're inexpensive, they have good air exchange, excellent pressure redistribution. Unfortunately, they do have a shorter lifespan. However, it's just one of the things you're going to see more commonly in these nursing homes. They're easy to clean. They may puncture or rupture, which is kind of a downside, but as long as they're taken well care of, you should be okay. One example is a Rojo high profile cushion. Hybrids or foams, you'll see these a lot. They help to adjust the correct posture. You'll see wedge cushions to kind of keep those patients in the wheelchair that try to stand up and have a fall risk. They are washable. They're easy to maintain. They don't have the puncture risk of the other ones. And some examples are like J seating, Infinity seating, and Flom technology. Some ones that you're probably not going to see very often unless it's a very specialized situation, or if it's somebody like a pediatric, which we don't see very often. There's some custom fabricated ones. These are actually made for that person's specific body. They're molded. They're very expensive. Like I said, anything that's very expensive, we know most likely isn't going to be provided. Ride cushions, these are custom molded as well. These may be for somebody who has, you know, a chronic condition such as, you know, quadriplegic, or some other, maybe they have a paraplegia or something, or ischial tuberosity. So don't really see those too often, but you may. This isn't something that you would order. This one, the last one, is a dynamic cushion, which is essentially like a low air loss alternating pressure mattress for the bed and for the wheelchair. I think they're great. They look amazing. I've never ever seen one in my entire nursing career on a wheelchair because they're pretty expensive. I can't imagine toting around this machine, attaching it to a wheelchair with everything else that a patient is potentially tagging along. But they are out there. You may see them. So in summary, proper offloading is imperative to wound healing, and ensuring that the patient is placed on the appropriate assistive devices aids in wound healing and the prevention of further wound development. These are an integral part of our plan of care. So it's important that you not only order it, that you document that you ordered it, and if it's not being followed, that you do any interventions that are appropriate to ensure compliance. All right, so G-tube replacement and troubleshooting. So we do a lot of G-tube replacements, and we have a couple different ones that we're doing. We do, and I'll kind of go into it, we do routine and urgent. So the G-tube coordination process, it starts with the office typically. So the office will get a referral from a referring agency saying, hey, I need an urgent G-tube, or I need a routine G-tube change the next time the provider's out. If it's an urgent G-tube, then they will send a message if it's in your area or if it's your account. Hey, you know, there's an urgent G-tube in this area. Can you take it? Once you agree to taking it, then if it's a home care patient, then we will go ahead and coordinate the x-ray to meet you there at, around the given time that you say you're going to be able to be there. If it is a facility, they typically coordinate that x-ray. Once you go and you do your G-tube, you will get a call from the on-call representative if it's after hours, or from the office, not a call, I'm sorry, a message on Slack giving you the KUB results and asking you to resume the feeding. So the supplies that you're going to need for this, and we do give you all of this, is the gastrostomy tube, of course, a 10 cc syringe, and that's going to inflate the balloon to keep it in place. Normal saline, a 60 cc syringe, which is typically at the facility for flushing, aspiration, and gastrografin injection. You'll need gastrografin, a T-Jane dressing, and silver nitrate isn't always needed, but it is something you should bring in the event that you do need it. There are two G-tube types that we typically use here. So we have Avanos Medline tubes, and then we have ENFit G-tubes. One thing that is important is to know which one is going to be placed, because they don't work together. And so this is like Apple and Android, they're not going to jive. So if you put an ENFit tube and they're using a different, they're not using a kangaroo pump, they're not going to be able to connect the feeding to their connector. So it's really important that we make sure we place the correct tube based on what feeding pump they're using. So as I mentioned earlier, we have our own little acronyms. We have UGT and RGT, so urgent G-tube and routine. And what the definitive factor in between them is, what makes them different, is urgent G-tube is any replacement that's needed right away for dislodgement, clog that they can't break through, or leaking due to broken or cracked tubing that is leaking that's significant enough to where it's causing issues. Ideally, we want these replaced within 6 hours. Of course, urgency does increase for certain situations, such as if they need seizure medication and they can't take it anyway but through the tube. If they have diabetes and the only way that they are getting any type of nutrition is through the tube, and if they have dehydration. In the event that we can't make it out there within 6 hours, we do communicate with that primary care physician, so they can either start IV fluids in the event that it's just like a dehydration issue, or they can transfer to ER for more urgent issues so they can be addressed sooner. Routine G-tubes are Typically done every 90 days, and this is really to decrease the risk of clogging, dislodgement, and cracking and leaking tubes due to age, right? So this coordination is typically, you know, when you're going to the facility that this week you're not just doing wound care, you're going to do the G-tube changes too. These are pretty much real. These ones are a little bit easier because you already know you're doing x-rays there. You just kind of go through fairly quickly on these. So bedside G-tube replacement assessment steps. So one thing you want to assess is how long has the G-tube been in place? Is it a PEG tube, a G-tube, or a DJ or a JT tube? Why is the tube being replaced? Is it leaking? Is it clogged? Is it dislodged? Or is it a routine change? And you want to assess the site. So you want to assess the tube size, the stoma size, look for hypergranulation tissue, and you want to assess the peristomal tissue. On the gastrostomy tube replacement steps. So first off, you want to remove the tube if it's still in place. If it is a PEG tube that does require manual removal, and Dr. Rosing, if you want to step in on how this one goes, because he can better explain it than I can if he's.
Yeah, the PEG tubes are basically are fixed, and it's a tube, and then at the end of the tube is like a mushroom type catheter about that big, a little bit bigger than a quarter. It's pliable, but it has to be pulled out through the stoma site. So the stoma site is typically the size of the tube, like a 22 French is what a PEG tube typically is. So it does require some like actual force. I usually will spray down the site with some lidocaine spray. If the patient's really worried about the pain, you can inject 1% lidocaine in there, but it typically is going to give them a little pain for sure. And I usually will use my left hand, put it on the abdomen to stabilize it, and then put like gauze in there. So the gauze will cover the stoma as soon as you remove it. And then I'll wrap the tube around my hand and you just yank. It's kind of like slow, constant pressure, but it has to be a fair amount of pressure. If it's an older person who doesn't have a very thick abdominal wall in terms of musculature, it can come out really easily. In younger patients who are more muscular, you have to pull it all the way through the muscular wall. So you really have to put some tension on there. So ideally, you'll get some experience seeing somebody do that before you have to do your own, because it is kind of one of those things where, you know, none of us want to hurt patients, but it is pretty, you do have to be fairly aggressive versus the normal G-tube, which I'll let Bianca get into there.
Yeah, the normal G-tube, much like a catheter, you're going to go ahead and deflate the balloon with the 10 cc syringe. Just to note, the balloon may sometimes be overfilled, so you want to completely deflate and keep pulling the fluid until you meet resistance. Then you just pull it out like you would a Foley. You just slide it right out. You want to cleanse the stoma and apply silver nitrate as needed. Some providers do it before they reinsert, some do it after. That's really up to your preference. You'll probably see both ways when you're out in the field, so do what you feel is best. Or sometimes it might not even be necessary.
Yeah, the silver nitrate's just in case there's hypergranulation tissue. If there's no hypergranulation tissue, then no need for silver nitrate.
And why would somebody do it before or after?
It doesn't really matter. The silver nitrate kind of causes a sort of like a dark brown gray color. So if you do it before, sometimes it doesn't stain the tube. So it's really just a personal preference. But either way, I usually do it after. The granulation tissue makes it easier to get the tube in. And if you really silver nitrate it really well, it could actually start to close the stoma a little bit, make it a little bit tighter and a little bit more painful for the patient. So that's why I do it afterwards.
Thank you for that. I know people are probably wondering what's the difference. So when you're replacing the tube, you want to insert the new tube through the stoma. You want to inflate the tube with a 10 cc syringe and adjust the stopper to the abdomen, not tight, not plushed against the skin where they're going to have some indentation or potential for a pressure injury. Just snug so it's not flopping around and risking being pulled out. And you also want to aspirate for the return of gastric contents. You then want to apply a tea drain dressing and then inject gastrographin, the gastrographin injection with KUB. Please note, and I'll go over here, you're going to use 20 cc's of gastrographin You're going to put that in the 20 cc, or in the 60 cc syringe. We're only pushing that in the presence of the x-ray technician, not before. And then once the KUB results are completed, the office will contact you with the results. And then once results are cleared, you can restart feedings and medications. And for any complications, call your supervising MD or message them for guidance, such as contrast seen in peritoneum, contrast in colon, unable to visualize tube in stomach, tube visualize outside of stomach, or inconclusive results. I think one of the reasons, and correct me if I'm wrong, that you would see contrast in the colon is if you pushed it before the KUB was there, and it was already kind of going through.
Yeah, it would be something if they had contrast in there from like maybe a previous study. Sometimes you guys will have, and usually it's barium. Gastrography doesn't last that long, but if somebody came back from the hospital, sometimes the barium will take sometimes even like a week to be fully out. So that's what they'll do that. The other way is that you've actually missed the stomach and somehow got into the colon, which I haven't seen happen, but there's always a possibility, I guess.
And once I'll say it again, the gastrographin does have to be pushed in the presence of the technician, so it's going in real time. Some troubleshooting issues. So if it's a new PEG tube, we should not be removing it.
Yeah, so I can go over the slide. So basically, PEG tubes will be placed by gastroenterologists, and it takes 4 to 6 weeks for that tract to fully form. Usually 6 to 8 weeks is a better time frame. So if the PEG tube has been in, say, 4 or 5 weeks and it's been dislodged, it's probably going to be the patient that's going to be best sent to the emergency room to have them replace the PEG tube. If that tract is not formed, the stomach can fall away from the abdominal wall, and then you're basically just pushing a tube into the abdomen. And that will end up being a surgical complication that the patient needs to have a surgery for. The other thing that you'll run into more often is PEGs can't be removed. So like I told you, you got to wrap your hand to kind of apply that significant amount of pressure, but if you can't get it out for some reason, and the patient's in too much pain, then that's another reason to send to the emergency room. I've never had that happen. However, I have put so much force that the actual tube and the mushroom tip literally separate. So you rip the tube out and all you see is the tube with no mushroom cap at the end. So that mushroom cap is now stuck either in the abdominal wall, in the stomach wall, or it's been dislodged and it's just floating in the stomach. So if it's floating in the stomach, it's going to pass the GI tract. A lot of the times the patients will just poop it out. However, it can get stuck in the ileocecal valve and cause a bowel obstruction. So if it gets stuck in that location, the patient within 24 hours will get signs and symptoms of a bowel obstruction, distension, nausea, vomiting, pain. If it gets stuck in the actual stomach or gets stuck in the subcutaneous tissue, then the stoma itself won't close. So these stomas will typically close after 24-hour periods. If they're open for like a week or 2 weeks, there may be, and this happened where the mushroom cap got ripped off. I then refer them to GI, and the GI doctors can then put a scope in and pull the mushroom catheter out from the inside. If it's stuck in subcutaneous tissue, then actual surgeon needs to remove it. So anytime this happens at a patient's house or in a skilled nursing facility, I let them know about those potential consequences because they need to know that if the patient develops small bowel obstruction, they need to go to the emergency room. And if the stoma isn't closed, they need to be referred to GI. So that's the kind of most typical things with the PEG tube. If you take out any kind of gastrostomy tube and you can't reinsert the tube, which does happen, the tract sometimes is complicated. If you can go to the next slide, Bianca, this is kind of something that you may end up seeing. This is a tube. You can see in the picture on the left, the redness that's around that tube. What's happened is that the gastrostomy tube and the balloon, which is about the size of a golf ball, has been pulled out of the stomach and now is residing in the subcutaneous tissue. So the practitioner removed the 10 cc's of fluid, and now you can see in the middle photograph there, basically like a golf-sized ball cavity. And that's been in the subcutaneous tissue for who knows how long. And they've probably been getting tube feeds as well, which is spread into the subcutaneous tissue and now is causing that redness and infection. So if you do get that, you can carefully try to get the tube back into the actual stoma and into the stomach, and then inflate the balloon. If you can't do that, that's someone that you need to send to the emergency room. But you can see in the picture on the right, they're able to reinsert that tube back into the stomach, blow up the balloon, and then what you do to create basically a seal, because now you've got this big gaping hole. I usually will fill it up with alginate, collagen, and then you snug down that stopper, so that will prevent it from leaking. And then I also silver nitrate that entire cavity so that it'll heal and eventually close up around the tube, and then you'll have a nice tight stoma again. I think that's it. What's the next slide there, Bianca?
X-ray.
Okay, yeah, and so if you can't see the contrast, you'll see KUBs come back. KUBs will come back saying that they can't see contrast. Typically, that means that the nurse at the nursing home or the caregiver in the patient's home has probably discarded the contrast, and they basically just do a KUB. And so you can't know. So on every single G tube that I do, every single time, I always will aspirate. And I'll kind of go over that. But if you don't aspirate, that means that you really will have no evidence that this tube is in the stomach. So you're going to have to drive back to that facility or that patient's home. So I've literally got home and been home for like an hour and then had to drive an hour back to administer the contrast. That's a total pain. So always aspirate. So what that means is that once you put the tube in and you've inflated the balloon, you can open up the stopper at the end. And if the patient's been recently feeding, tube feeds will immediately just start spilling out. You know that you're in the stomach, just close the stopper and you can flush it. If the patient's been NPO for like, I don't know, 12 to 24 hours, because sometimes they have been when we're replacing these, the stomach a lot of the times is collapsed around the tube. So I'll inject 60 cc's of normal saline or water. They always have water at their bedside. And then once you've injected it, you want to like aspirate back and see if you get stomach contents and fluid. Sometimes you're going to get suction, and that just means the stomach's collapsed around the tube. So then I'll inject like literally 120 cc's of just air, just an air-filled syringe, 2 big injections, and then I'll inject about 30 to 40 more cc's of water or saline, and then try to aspirate. And then if you can get aspirate back and you know you're in the stomach, then at least you know you don't have to drive back for contrast per se. The other possible problem is having contrast extravasation. So if that happens, you'll see it on the x-ray or you'll see it on the x-ray reading. And what that means is that the tube has not gone into the stomach, but you've actually got in between the stomach and the abdominal wall from the inside. And now the contrast is basically just going freely into the peritoneum. So they typically see it over the dome of the liver or around the spleen. And so that tube basically is not in the right spot. It's not in the stomach. It's directly into the peritoneum. So if you start tube feeds, that patient's going to get peritonitis and they're going to have a surgical procedure. So if that is seen on an x-ray, those patients need to be transferred to the emergency room so they can remove that tube and then either try again in the emergency room under fluoroscopy, or they'll have a surgeon come and take care of it. Contrast in the small bowel typically is normal. You're going to, sometimes if the contrast has been in there for a couple of minutes, it can make its way from the stomach into the duodenum and it'll only be in the small bowel. That's usually okay. It really shouldn't be in the colon, like we said before. If it's in the colon, it's either a really bad G2 placement, and believe me, you'd have to use a lot of force to get through the colonic wall. So you should never be forcing these. They should always go easy. But more than likely, it's just contrast from a previous CAT scan or something like that. And the next slide, Bianca. Okay, I'll let you go there.
Okay, so what is gastrographin? And it's really a sodium, and I'm never going to say this right. Dr. Rosen's always going to make fun of me. Amdotriazote, whatever. I'm never going to say it right.
Amdotriazate.
See, I am not good at pronouncing things. I'm a stereotype. I'm just never going to say it right. So there's some inactive ingredients like star anise oil, polysorbate 80, saccharin, sodium, and disodium edetate. So the mechanism of action is pharmacotherapeutic group X, our group X-ray contrast media. It's iodinated and water soluble. I cannot talk. So this does not exert a pharmacological effect, and it is an iodine containing a contrast medium. So we want to make sure that when we're ordering this, that we make sure they don't have any iodine type sensitivities. So gastrographin is a contrast medium for the radiological examination of the gastrointestinal tract. It can be administered orally through an NG tube or a gastrostomy or as an enema. Here, we're just going to use it in the G tube. We're not doing anything else. So therapeutic indications can be used for meconium ileus and partial or small bowel obstruction, where, like I said, we're only using it as a tool to assess the placement of G tubes. So the dosage is the 20 cc's non-diluted. Typically, you're going to do it with 10 cc's of air also. And that air is only to ensure that that is going to be pushed through the tubing all the way into the stomach and there's none stuck in the tubing. So you want to ensure that the syringe is aimed downwards, pushing the gastrographin in first, then allowing the air to clear the gastrographin from the tube, and then close the port. Like I mentioned earlier, only push the gastrographin in the presence of the X-ray technician. The X-ray technician in some situations may want a scout image prior to gastrographin administration. Special warnings and precautions for usage. So you want to, any allergies, do they have any seafood allergies, hay fever allergies, or any hives, any sensitivity to iodine or radiographic media? Typically, we should know this because it most likely isn't their first time they've had the G-tube changed. It most likely isn't the first time they've had it. So we should know if they have any sensitivities to those things, or if they have a presence of bronchial asthma. And the reason for that is there is a reported incidence of adverse reactions to contrast media, which is higher in patients with those conditions. Pre-medications with antihistamines or glucocorticosteroids may be considered, but check with your primary care physician. Some additional special considerations to take into consideration is hypothyroidism. Are they on any beta blockers? Do they have any cardiovascular disease? Do they have hypovolemia or any fluid or electrolyte imbalances? Are they pregnant? Because the safety is unknown on that. Some side effects are nausea, vomiting, diarrhea, abdominal pain, myoangioedema, coughing, a runny nose, urticaria, pruritus, TENS. Respiratory, they could have some bronchospasms or aspiration. So these could be initial signs of impending shock. So be, really vigilant on these things. Any hypersensitivity reaction intervention. So one thing to note, we're not in a hospital. We're not going to have all of the typical stuff that you would in an acute care hospital, like with a crash cart. If you're in a nursing home, they will have a crash cart, but that crash cart is really going to be an ambu bag and a backboard. There's really not going to be much medications on there, if any. So first thing you want to do is call 911, bring the crash cart to the bedside. If you are in a nursing home, in a home environment, of course, that will be different. Administer Benadryl 50 milligrams through the tube or oral IV or IM based on what is available. Have EMS administer epinephrine because, like I mentioned, in a nursing home, they're not going to have epinephrine available. So you are going to have to wait for emergency medical systems to come and assist with that, but only if cardiopulmonary symptoms are present. Of course, you want to notify the family, and you want to document the incident and note in the chart the allergy to the medication. So peristomal skin management. Leaking stoma, so you want to address any leaking stomas. You want to look at the tube size. There are times where you will size up on a tube. If they've had that leaking, and that leaking is not necessarily caused from it being cracked or broken, it's leaking because the stoma is bigger than the tube. You want to upsize on that tube, and you want to add any additional treatment options, replacement bands, tape. You want to make sure that everything, you put the T drain, you're putting some extra gauze around it if it is leaking to absorb that, so it's not going on the patient's good skin and causing any maceration. If they do have dermatitis around that area, you want to rule out any signs of infection. And with the hypergranulation tissue, as we mentioned earlier, you can use the silver nitrate to treat that. Any questions? Because this is it. We're done with all of my stuff right now. Questions, comments, concerns? I know there's a lot of information.
And when it comes to G-tubes, you'll have plenty of experience in the field where you'll learn about all of these things. So don't freak out about it. All of this information is a lot, and there's more coming. But that's the reason why it is recorded. It is something you can kind of go back and check out. And then we really want to get the when you're shadowing in the fields and whatnot, so you can understand how everything kind of works, get the flow of everything. And I think we probably should take a break for like, I don't know, like 20 minutes or something like that, 30 minutes. And then I can go over the clinical slides. I'm just going to go over wound healing and the different kinds of etiologies of wounds. And then I'll show you how to go over the shorthand notes, and then we'll go over different kind of dressing types, the most typical ones that we use. And then you'll be done for the day. So is everybody cool with taking like a 20-minute break? All right. So maybe back at like 12:20. No hurry though.
12:20?
Sure.
Okay.
If you need longer, that's okay.
You want to give them 12:30? It is.
Yeah, 12:30 is great. 12:30 is
Okay, perfect. 12:30, guys. We'll see you guys back.
awesome. Thank you, guys.